Okay, welcome back, guys. We'll be anyways starting finally. People can hear and see me, right? Okay, so we'll be starting it. So there'll be no delay from now on. Okay. And with this, I think when you're attending the live sessions, you'll be able to move my image here and there also so that there will be no wastage of space. Class schedule, I will let you know. So what are the class schedule? First, we'll start with nephrology today because the reason why I can't do the green screen right now is I'm in home and I am not fit to move yet because I've undergone a surgery. So I will be able to take from home only. So that is the reason why I don't want to waste time also. And at the same time, I'll finish off the portions in this 3-4 days. But nevertheless, that is the reason why it was not like before. But nevertheless, I think this will be easier for you as well. So one good advantage of this is I think you can move my image here and there. So wherever you want, whenever I'm writing, because it's in Zoom, you can move here and there. Not an issue at all. So that must be it. But now however, like I think you'll be able to see and hear me properly, right? No problem. Okay, fine. Cool. I think we have some more nephrology topics that is left. That's what we're going to do today. The first one being the glomerular disorders. That is what I wanted to discuss first. So let me start with that. So the glomerular disorders, which are very important for exams. As far as exams are concerned, there are few topics that are important in nephrology. One is the acid-base balance. That is the most important, definite one question from that, which you have discussed already. And the second one, which is more important, is the glomerular disorders. So there will be almost a question always from glomerular disorders if they wanted to ask one question from nephrology section. So let us start with glomerular disorders to be precise. First of all, we need to know the ultrastructure of the glomerulus because this is not that simple, even though glomerular disorders are little rare in reality in clinical practice. But when it comes to exams, it's going to be very common. And at the same time, diagnosis of these glomerular disorders are not that simple. So we have primary disorders, secondary disorders, and so many other problems are there as far as glomerular disorders are concerned. So that is the reason why we need to be a little cautious in understanding what do you mean by glomerular disorders in the first place. So what are the ways that glomerular disorders can present? So presentation. So let me start with an audience. So what are the ways of presentation that you guys know? So that I can build up from there on. So you can answer or you can just give me some answers. So what are the ways that glomerular disorders can present? I think almost there are 30 plus participants and of course, right? So what are the ways of presentation? Okay, hematuria with 45-1 rule. I don't know why you wanted to be that 45-1 rule. That's a very, very old one in the sense like it was a very one of the times they asked in 2003 or 2004 All India question. So that is where they asked that percentage of dysmorphic RBs that is needed to diagnose a glomerular hematuria. But that's extremely old scenario and we don't even follow that. So the most important is the RBC cast. Just one RBC cast is enough to tell that it is a glomerular bleed. So that is what I wanted to tell in the first place. So I'm not asking about the hematuria or proteinuria. First thing I need to know what are the types of presentation. Number one, we have something called a nephritic presentation. Second one, we have something called a nephrotic presentation. And we have a third one that is called as an RPGN, that is called rapidly progressive glomerulonephritis. They can have this RPGN kind of a scenario. Number four, they can present with chronic glomerulonephritis, or otherwise they can present with CKD as well, either a chronic glomerulonephritis or even like a chronic kidney disease. And number five, they can come with an isolated hematuria or proteinuria, which may not be even symptomatic. Isolated hematuria or proteinuria. So these are the ways of presentation. So this is how they're going to present basically. So to start with, when you call a patient is having a nephritic syndrome, so we know that there are certain classic hallmarks of how a nephritic syndrome is going to present with. So typically a nephritic syndrome will have this particular triad. This triad is variable in different textbooks, but the usual triad says that this patient will have AK, Did I cover about AK? I think I have not told about the definition of AK. Let me talk about the definition of AK after some time. So they can come with acute kidney injury. At the same time, they can have hypertension and they will have hematuria. At the same time, they do have proteinuria, but very importantly, they will have hematuria. This hematuria, as Keshav initially told, there is a 45-1 rule, which is very old scenario, but right now we don't use those kind of rules. But nevertheless, if you want to know that this hematuria is of glomerular origin, there are three things that we need to know about it. So number one, what we need to know is the RBC cast. So that is more important. So this is the quintessential point. That is the RBC cast. And apart from that, we need to know that this patient can have dysmorphic RBCs, or this patient can have few acanthocytes as well. But right now, nobody calls about acanthocytes, but in general, if you have some kind of dysmorphism in the RBCs, that's enough to diagnose it's a glomerular cause of bleed. So as I already told you in rheumatology, if you have at least 40% of dysmorphic RBCs or at least 5% of acanthocytes are just a single RBC cast. Just if you see one RBC cast, that's enough to tell that this patient is having a glomerular origin of hematuria. Fine. So it's not the only thing that this patient may have an associated proteinuria as well, even though hematuria is a prominent finding in nephritic presentation. Proteinuria may be there. And we know how much proteinuria should be there to tell that it is a glomerular bleed. So approximately, maybe we can talk about more than 0.5 grams per day is significant. And usually in typical nephritic syndrome, patients tend to have proteinuria, but it will not be like nephrotic range. Usually it will be subnephrotic range only. Subnephrotic range proteinuria. So what do you mean by subnephrotic range? Subnephrotic means it should be less than 3.5 grams per day. So this is what we refer to as subnephrotic range. Usually the proteinuria will be there more than 500 milligrams per day or more than 0.5 grams per day. But in general, it will be in the subnephrotic range. It will not be in the nephrotic range proteinuria. That's a classic of a nephritic presentation. Apart from that, we know how fast the AK happens. AK usually happens in days. It means it's a kidney function that happens in days. Cystocytes are equal to acanthocytes. No, acanthocytes are something different from cystocytes. Acanthocytes will have more of a projection kind of a scenario. In cystocytes, it will be fragmented RBCs. It's more of a tiered RBCs, like it's in an irregular shape. Bite cells are different. So that happens in typical G6PD deficiency or many other hypersplenism, where the splenic macrophages bite a particular corner of the cells. So that's a little different. Acanthocytes are not exactly equal to the cystocytes. Cystocytes will be seen in more of a microangiopathic hemolytic anemia. But nevertheless, we know why this hematuria is of glomerular origin, having this dysmorphic RBC and all this stuff, because whenever they move through this small filtration slits that is present in the glomerulus, there might be the twisting and changing of the shape of the RBCs while moving through this small pores. So that is the time where they get dysmorphed and they look like as if they are battered and bashed while they're passing through the glomerular or this filtration slits. But nevertheless, the most important point to know here is that this patient will have AK that happens over a period of few days, not months or years, so very few days, in the sense like it will be in hours also sometimes. So this is very characteristic of a nephritic presentation. And at the same time, this hematuria can be either a microscopic hematuria or even a macroscopic hematuria, doesn't matter. It can come as a gross bleed or it can come as a microscopic bleed, doesn't matter. So this is a classic presentation of a nephritic syndrome. And on the other hand, if you take a nephrotic syndrome, they're going to present in a little different way. The most important feature of nephrotic syndrome is going to be the proteinuria. That's going to be important. Proteinuria is the most important point as far as nephrotic syndrome is concerned. And proteinuria will be typically massive, more than 3.5 grams per day, even though there are some different definitions of massive proteinuria in very old textbooks before 2005, 2006, where they called as more than 4 grams as massive proteinuria. But currently, there is nothing to tell like massive proteinuria is different from nephrotic range proteinuria. Both are almost similar. Whenever the proteinuria is more than 3.5 grams per day, it is highly significant and it is nephrotic range proteinuria, and it is of course going to be a massive proteinuria as well. There's no clinical or functional significance that you're going to gain by knowing what do you mean by massive proteinuria, what do you mean by nephrotic proteinuria. Both are almost going to have extremely high clinical significance. But nevertheless, proteinuria is the most important feature. And because of proteinuria, there are multiple counter effects you will get. Like for example, the patients will have hypoalbuminemia, typically defined as less than 3.5 grams per deciliter of albumin. Hypoalbuminemia will be there. And apart from that, patients will have edema. That is because of a lot of reasons. There are many theories why you get this edema and volume overload in patients with nephrotic syndrome. Typically, there are two hypotheses we know. One is called underfill hypothesis, and second one we have something called the overfill hypothesis. So underfill hypothesis states that the edema is due to basically hypoalbuminemia, and it is due to low oncotic pressure. Because the low oncotic pressure, naturally you will result in edema. So that is what the underfill hypothesis tells. The overfill hypothesis tells that this low oncotic pressure causes low perfusion to the kidneys. Low perfusion to the kidneys can result in hyperactivation of renin-angiotensin-aldosterone system. Hyperactivation of renin-angiotensin-aldosterone system. And this is going to result in sodium overload, increased sodium reabsorption. So that is the reason for developing edema. So anyway, so the current evidence favors the overfill hypothesis than the underfill hypothesis, but nevertheless, hypoalbuminemia as a standalone cause of edema is obsolete right now. So anyway, nevertheless, you're going to get edema in these patients. And many nephrotic syndromes can present just with edema, not with anything else at all in the first place. So that is number 2, edema. And number 3, their susceptibility to infections. There is increased susceptibility to infections that can happen in patients with nephrotic syndrome, especially typically capsulated organisms. And at the same time, among the capsulated organisms, more importantly, you will result in pneumococcal infections more commonly. So whenever a nephrotic syndrome patient is getting some infection, maybe pneumonia, or maybe they might have ascites, that ascites may have spontaneous bacterial peritonitis, whatever may be the case, if they ask you what infection that the nephrotic syndrome patients are highly prone for, that is pneumococcal infections. That's why most of the kidney disease patients, especially nephrotic syndrome patients, or if any kidney patient is having severe proteinuria, we always give a pneumococcal vaccine. That's very important there. So because there is a high susceptibility of getting infections there. More importantly here, the immunoglobulins will be lost. And that's one of the main reasons why these patients are at higher risk of developing infections. And number 4, they will go for hypercoagulable states. Hypercoagulable states. This is also very important to understand. And hypercoagulability is due to a lot of reasons. One is due to gain of procoagulant factors. I mean, relative gain of, not just gain, relative gain of procoagulant factors like fibrinogen, which are huge molecules, so don't get filtered that easily, even in severe loss of the filtration slits. But on the other hand, the smaller proteins, anticoagulant proteins like protein C, protein S, antithrombin 3 can easily leak out in the glomerular disease disorders through the filtration sleeve. So that's why there's a relative imbalance that's happening. There is more procoagulant factors compared to lesser anticoagulant factors. So that is the reason why you get hypercoagulability. But one nephrotic syndrome typically has the highest chance of hypercoagulable state. So what is that nephrotic syndrome? This is a very straightforward question. People who are preparing for NEET PG exam should be able to answer this question, which is very simple and straightforward. So what is that nephrotic syndrome that has an extremely high risk of developing hypercoagulability? Yes, correct. So that is membranous glomerulonephritis or membranous nephropathy. Membranous nephropathy typically has an extremely high risk of developing hypercoagulable state, and which is one of the very commonest sites for experiencing this hypercoagulable state. Commonest site probably, maybe. So site, if they ask you which site, they go for this thrombosis. Typically, it's the renal vein thrombosis. That's what I want to tell. So most often it will be bilateral. It can be unilateral, but most often it will be bilateral. So the renal vein thrombosis is very, very important. So that's the characteristic site where the patients go for thrombosis in patients with nephrotic syndrome. And membranous glomerulonephritis, due to a lot of unknown reasons and unexplained reasons, they are having a highest risk of developing this renal vein thrombosis and hypercoagulable state. So these are the characteristic features of nephrotic syndrome. It doesn't mean that these patients with nephrotic syndrome won't have hematuria. They might have associated hematuria. It's not like hematuria is not a feature of nephrotic syndrome. They might have hematuria. And hematuria, and especially the glomerular origin type of blood, is characteristic feature of any glomerular disorder. It's not like just you will be seeing in a nephrotic syndrome and not in nephrotic syndrome. It can be seen here also. Ultimately, so what do you mean by RPGN? Can anyone tell the exact definition of what you mean by a rapidly progressing glomerulonephritis? It's different. So we know that acute kidney injury or acute glomerulonephritis happens in a few days, and whereas a chronic kidney disease or a chronic glomerulonephritis or a chronic kidney disease happens in few months, maybe. Typical definition is 3 months, which we'll be discussing after some time. But RPGN is something that is in between an acute glomerulonephritis versus a chronic glomerulonephritis. So many students think that rapidly progressing glomerulonephritis means it happens within few hours. No, not like that. Rapidly progressing glomerulonephritis is something that happens in a time frame that is in between the acute glomerulonephritis or acute kidney injury versus a chronic glomerulonephritis, which means it might happen over a period of weeks. That's what I want to tell. But in general, there are few definitions in the world that tell that rapidly progressing glomerulonephritis, usually there will be doubling of the serum creatinine over a period of 6 weeks. So this 6 weeks you can remember in the exams as a definition of rapidly progressing glomerulonephritis. As I told you, AKI or acute glomerulonephritis happens in days. Chronic glomerulonephritis happens over a period of months. So if you want, I can write here also. They happen in a period of months. Whereas RPGN, rapidly progressing glomerulonephritis, happens over a period of few weeks. By definition, you can remember doubling of serum creatinine within 6 weeks is classical definition of a rapidly progressing glomerulonephritis. And that in nephrology has been extrapolated to many other conditions because we sometimes don't know that it's a rapidly progressing glomerulonephritis. So we extrapolate that and tell something called as an RPRF, that is rapidly progressing renal failure. So any doubling of serum creatinine that happens within a period of 6 weeks, but not within a period of few days, that will be called as a RPRF, that is called rapidly progressing renal failure also. So sometimes in nephrology, the RPGN and RPRF are basically equated with each other. So you need to be a little careful about that terms as well. So now we know. So there are a lot of conditions which can present just with isolated hematuria or isolated proteinuria also. But whenever you have an isolated proteinuria, you have multiple other benign differential diagnoses rather than a problematic differential diagnosis like glomerular disorders, even though glomerular disorders is one of the differential diagnoses for that isolated proteinuria. Most of the time, if you encounter the word isolated proteinuria, it will be benign. Most of the times, if you encounter the word called isolated hematuria, that will also be benign. But there can be a rare possibility that these patients might have a glomerular disorder as well. So this is what you need to know. So now you will be understanding what are the different presentations of glomerular disorders, right from nephritic, nephrotic, RPGN, CGN, isolated hematuria, as well as isolated proteinuria, which is pretty important for exams. At the same time, it's not like edema will not be a feature of nephritic disorders. Edema can happen in nephritic disorders as well. Proteinuria can happen in nephritic disorders as well. Even hypercoagulopathy can happen in nephritic disorders. So there are a lot of overlaps between this nephritic and nephrotic. You cannot really tell that nephritic means you will not have edema and like hypercoagulable state. They may also produce that. So there is a substantial overlap between them, which is very important to know. And at the same time, one more interesting thing that you need to know is that what will be the histological feature. There will be some common histological manifestation of nephritic versus nephrotic. Suppose if you take a nephritic syndrome, the common histological feature will be something called as a proliferative glomerulonephritis. This proliferation is very classic of a nephritic syndrome. Very, very important. Proliferation, this proliferative pathology. Whereas in nephrotic presentations, if you take the histology and see, they'll be having a non-proliferative pathology. Non-proliferative pathology. Non-proliferative in the sense they won't have any element of proliferation at all in the first place, which means there might be some acellular components that can thicken, like thickened base membrane may be seen, but you generally don't encounter a proliferative pathology. And again, there is a substantial overlap in them. You cannot be extremely sure that this means it's a proliferative pathology and this means it's a non-proliferative pathology, but there is a substantial overlap between them. But in general, proliferation will be more severe in nephritic kind of presentations, and as well as nephrotic presentations will have more of a non-proliferative pathology. But everyone knows what happens in RPGN. We know what happens in RPGN. In RPGN, the classic histology that you see is very simple. I can expect some answers from you guys, isn't it? So what do you see in RPGN? The sense like that's called as another name also. What do you see generally? Yes, of course, that's a very simple thing. So it's also type of proliferation only. So you will see a proliferative pathology only here also. It's not like you don't see a non-proliferative pathology. This proliferative pathology typically will show one characteristic feature in RP gene that is called crescents. That's very characteristic. And that's why this RP gene is also referred to as something called crescentic glomerulonephritis. But more often, as a clinician, I don't use the term RPGN. Rather, in clinical practice, I use the term RPRF rather than RPGN. And whenever I see crescents, I don't use the term again RPGN. I use the term called crescentic glomerulonephritis. So that is the right term. RPRF with crescents is what we called as an RPGN, rapidly progressing glomerulonephritis. So this is how RPGN is going to come. On the other hand, as far as chronic glomerulonephritis is concerned, you know how chronic glomerulonephritis will present with. Chronic glomerulonephritis histology, where I can write, maybe I can write here. If you take the histology of chronic glomerulonephritis, it depends on the underlying feature, underlying pathology, but more often they're going to come with glomerular sclerosis. More often they'll be having glomerular sclerosis. At the same time, they'll be showing some kind of tubular atrophy and interstitial fibrosis. Trust me, like in any CKD patient, this is going to be the classic hallmarks: glomerular sclerosis, tubular atrophy, interstitial fibrosis, or tubular interstitial fibrosis. So this is going to the characteristic histology in any chronic glomerulonephritis. Apart from that, they might show other features that are typical of a nephritic or nephrotic presentation, or an RPGN also. They might show some crescents which show some activity also. Doesn't matter, but if you see glomerular sclerosis, predominantly tubular atrophy, interstitial fibrosis, that usually goes towards a chronic disease, or any chronic glomerulonephritis or a chronic kidney disease or a chronic tubular interstitial disease. Doesn't matter. Depending on which is more involved, you're going to localize the lesion there, that this is going to be the characteristic pathology. And isolated hematuria and proteinuria, you don't have a specific pathology. Again, it may be either nephritic, nephrotic, chronic, doesn't matter. So it doesn't have any specific histological picture on its own. So the first three are very, very important: nephritic histology, nephrotic histology, and RPGN histology, which is very important, and we have discussed that already in exams. So these are the different and important manifestations of glomerular disorders. So do you understand this, so that we can move on to the general management of glomerular disorders? Yeah, it's simple, isn't it? It's quite simple. So that's all. These are the 5 things that you need to know in the first place. Everything integrated into a common place. So let us move on to the general management. As we move on to the general treatment of glomerular disorders, number 1. So, later on we'll, push one by one, but let us first start with the general management. So general management initially is dependent on the hypertension, because majority of the nephritic as well as nephrotic disorders will have hypertension. As far as hypertension is concerned, the most important thing is the lifestyle modification that you need to know, especially in the diet and exercise. More importantly, the diet is very important. The patient has to stop smoking, because smoking is a very important, strong risk factor for progression of a kidney disease. So they have to stop smoking. They have to reduce weight. If in certain conditions like FSGS, which is actually very much related to body weight, morbid obesity is one of the important risk factors for developing FSGS. So reduction of weight becomes very important, and at the same time, salt restricted diet is also very important. Typically less than 2 grams of table salt per day, or less than 1.5 grams of sodium. So this is what we advocate to the patients. As far as the target BP is concerned, remember ACC-HA universally tells for any kidney disease, it is less than 130/80. But there are separate guidelines from KDIGO-KDOQI guidelines. So that's a kidney society guideline that was last given in 2012. After that, they didn't update that much, where they told overall goal. This is not ACHA, but we have a separate KDIGO-KDOQI recommendations. As for the KDIGO recommendations are concerned, the overall blood pressure should be less than 140/90. And if the patient is having proteinuria more than 1 gram per day, which means the patient is having significant proteinuria. If it's a non-significant proteinuria, then you can keep this as a goal. Suppose if the patient is having a significant proteinuria, then BP less than 125/75 may be the ideal goal. So when you call the term significant proteinuria in a glomerular disorder or any disorder, it is more than 1 gram per day. Whenever the proteinuria is more than 1 gram per day, we call it as significant proteinuria. And whenever the patient is having significant proteinuria, it's better to keep the goal to less than 125/75, much lower cutoff. Okay. The reason why in significant proteinuria we keep a lower BP is because BP causes hyperfiltration. The more the blood pressure, more the afferent arterial pressure, and more the filtration you're going to get, and more the proteins are going to leak. So that is why in higher BPs, it's better to keep, in higher proteinuria, it's better to keep a lower blood pressure as a target. And as far as the proteinuria is concerned, to control proteinuria, there are many things are there, but more importantly, you can give antihypertensive therapy. So which means you're going to control the BP, number one. That's very important. At the same time, you need to give ACE inhibitors or angiotensin receptor blockers. We know any one can be started, either ACE inhibitors or ARBs, but one has to be given. And at the same time, you need to control the hyperlipidemia also, because nephrotic syndrome is something which I didn't mention here, but nephrotic syndrome is something where it causes lipids to go RE. So these patients will have hyperlipidemia, as well as these patients might be having lipiduria as well. I think this lipiduria is the one that produces fatty cas. Like there you saw RBC cas like that, they're going to produce fatty cas. And I already told you, I think I've showed you this image in the previous session itself. In polarized microscope, they are going to be seen as something called Maltese cross bodies. Maltese cross appearance. And these fatty cas also form something called oval fat bodies. And these oval fat bodies are the ones in polarized microscope. When you see, they appear like Maltese cross. I think I've showed you the image as well, I guess. But nevertheless, you need to know about oval fat bodies that are seen in nephrotic syndrome and Fabry's disease. In polarized microscope, both these conditions can produce Maltese cross-like appearance. So that is due to the significant lipiduria. As far as hyperlipidemia is concerned, there are a variety of changes that can happen in hyperlipidemia. Typical thing is that the LDL levels tend to increase due to a lot of variety of reasons, and that itself increases the risk of cardiovascular death in these guys. At the same time, overall, the non-HDL cholesterol tends to increase in these patients, but HDL cholesterol may remain the same, or there might be a slight decline may be there, and triglycerides generally tend to increase. So there are a lot of changes that happens, but in general, this hyperlipidemia itself will increase the risk of cardiovascular death. Especially the LDL tends to increase by 20 to 30% in patients with nephrotic syndrome. That's a very important point as well to know. Hyperlipidemia in patients with nephrotic syndrome. So how will you manage this hyperlipidemia? Typically, whenever the patient is having hyperlipidemia or dyslipidemia, we typically manage with statins, which has a very protective role for cardiovascular health as well. We have discussed in detail. And patients can have significant edema that can affect the quality of life very badly. So typically we add loop diuretics in these patients. This is the best choice. Plus or minus, I can add many other diuretics like thiazide diuretics. Suppose if the edema does not resolve with loop diuretics, I can add thiazide diuretics, or probably I can give a potassium sparing diuretics as well. We know there are two types of potassium sparing diuretics. The first type is the MRAs, mineralocorticoid receptor antagonists like spironolactone or eplerenone. And second type of drugs are epithelial sodium channel blockers like amiloride. In our setup, in my hospital, the potassium sparing diuretics are extremely common. We don't use thiazides that often for kidney patients. We use more of potassium sparing diuretics if the creatinine is less than 2.5. Remember, for using potassium sparing diuretics, creatinine should be less than 2.5. Creatinine is more than 2.5. Spironolactone or eplerenone are absolutely contraindicated. You should not use that. That's a very important take-home point. So nephrotic syndrome patients, many times they will have a normal creatinine or only mildly elevated creatinine. So it's okay for us. So we add a potassium sparing diuretic in most of the patients. Okay. Then the fifth one is the hypercoagulability. Hypercoagulability has to be managed. So the risk of hypercoagulability is more in certain situations. I told you one of the inherent causes that produces more hypercoagulability is the membranous nephropathy or membranous glomerulonephritis. But apart from that, there are certain other things itself as a whole can increase the risk of hypercoagulability in patients with nephrotic syndrome. Like for example, if the serum albumin is very, very low, not just less than 3.5, it's very low, less than 2.5 grams per deciliter. Then if the patient is having proteinuria more than 10 grams per day, extremely severe proteinuria, more than 10 grams per day, or the patient is extremely obese, BMI more than 35, morbid obesity, that's also a definition of morbid obesity. Patient is having BMI more than 35. And if the patient has a family history of thromboembolism, the patient has family history of thromboembolism, or if the patient has a underlying thrombophilia, like APLA antibodies are there, or factor V Leiden mutation is there, or the patient is having already a background NIHA 3 or 4 heart failure, or the patient is having a prolonged immobilization, which might be due to any reason more than 3 days if the patient is getting immobilized, or the patient has gone for recent surgery, especially the abdominal and orthopedic surgeries, which can be there. So if any one of them is present, if anyone is present in these patients, they are at very, very high risk and significantly higher risk of developing thrombosis and hypercoagulable state. So we need to add heparin. Clear? So my question will be whether the dose of the heparin in these patients will be high, or dose of the heparin in patients with nephrotic syndrome will be low. The dose of heparin needed in nephrotic syndrome patients will be high, or dose of heparin needed in nephrotic syndrome patients will be low. That's the question. So if you want to tell high, you want to tell the reason. If you want to tell low, you want to tell the reason. Actually, the dose of heparin that is needed in these patients will be very high. They won't really respond to low dose heparin. It's not due to low albumin. The reason why they need a high dose heparin is because heparin generally acts on antithrombin 3, and the number of antithrombin 3 molecules in patients with nephrotic syndrome is actually low because they lose antithrombin 3 in the urine. So because of the lower levels of antithrombin 3, you need a high dose of heparin usually. And what heparin you prefer? Typically, we prefer a low molecular heparin. But remember, it is renally eliminated, so you have to adjust according to serum creatinine. Versus you can start an unfractionated heparin as well. But unfractionated heparin, one advantage is it need not be adjusted. But we know that unfractionated heparin has a higher risk of producing heparin-induced thrombocytopenia compared to low molecular heparin. But anywhere in hospital situations, if you ask, the standard is always low molecular heparin. But you can start with unfractionated heparin at certain situations where you are not sure about the low molecular heparin because of the high serum creatinine. So in that situation, you can think about. And at the same time, these patients may have risk of infections. How you are going to manage the infections? Especially, I told you, pneumococcal infections are extremely common. So we need to give pneumococcal vaccine for all patients. Any patient with glomerular disorder, especially a chronic glomerular disorder, pneumococcal vaccine is a must. That's very, very important. So suppose the patient is going for recurrent infections. So the patient is going for recurrent infections again and again and again. Recurrent infections in this scenario, then probably you can think about infusing an IVIG. So especially if the serum immunoglobulin, IVIG can be considered in certain nephrotic syndrome patients, especially if serum IgG is less than 600 milligrams per deciliter, then this becomes an indication for IVIG infusions. So that's what we do actually. If you work alongside me in the hospital, you'll be knowing. See, these are extremely practical points. So, I mean, what I emphasize on whenever I teach my residents or something is these kind of small issues. This is what really matters in real life. I don't think there are certain other things that are going to matter. So these are things that really matters in real life. So there is patient who's coming with recurrent infections or very high risk of infection. If I feel, I usually transfuse IVIG because in our hospital, IVIG we use like water. It's something we use very commonly. So we use that very often. So that's why I know this. And all patients will receive pneumococcal vaccine. Suppose if they get a pneumococcal infection, the best drug will be some penicillin group of drugs because many of the pneumococcus will respond to the benzyl penicillin itself. So that's not a big deal. So these are the general management strategy as far as the glomerular disorder patient is concerned. I think you will be aware of this, so that's not a big deal. So do you understand? So that we can move on to the next step and individual nephritic and nephrotic disorders. Yes, cool. And we need to know about certain terms in glomerular disorder. So what are the terminologies that you need to know? So the histological terms. So before moving on to that, so let us start with some histological terms. So what are the histological terms? The first histological term is, I told you, proliferative term. So when you call it as proliferative, whenever you call it proliferative, there is increased number of cells. So this is what we call it as proliferative histology. So any kind of cell, it could be this cell, could be, for example, a capillary endothelium, or it could be a visceral epithelial cell, or it could be a parietal epithelial cell, doesn't matter, or this could be even mesangial cell, mesangium. But something is proliferating, some cellular component is proliferating. This is what we called as proliferative pathology, number one. Apart from that, we have something called as sclerosing pathology. Sclerosing means we know it's fibrosis, it's nothing but a scar tissue. So this is what we call as sclerosing pathology. Number three, we also have necrotizing pathology, which is very commonly seen in some ANCA-related disorders, which I told you already. Focal segmental necrotizing glomerulonephritis is characteristic feature of ANCA-related nephritic syndrome. So necrotizing pathology, where there will be some areas of necrosis or cell death will be there. And at the same time, we have, dependent on the number of areas that are involved, we have something called a focal versus diffuse. As far as focal is concerned, you have less than 50% of the particular glomerulus involved. So which means of the total number of glomeruli are involved. For example, if you take a particular slide and you are seeing 10 glomeruli, if only 3 glomeruli are involved, so that's called focal. And second one, we have something called a diffuse, where more than 50% of the glomeruli will be involved, which means if you take same 10 glomeruli in a particular field, if 6-7 glomeruli are involved, so we can call it as more than 50% involvement. 50% of the number of glomerulus are involved. That is what we refer to as a diffuse pathology. And at the same time, we have something called a segmental versus global. Segmental pathology. Segmental means in the involved glomerulus. If a particular glomerulus is involved in an area, we take a single glomerulus. In that glomerulus, if only less than 50% of the tuft of the glomerulus is involved, so that is what we call as a segmental pathology. Apart from that, we have something called a global pathology. So usually it is 100% involvement, which means the entire glomerulus is involved. That's what we call it as a global, but by definition, it is more than 50%. More than 50%, we can call it as global, but in reality, global means the entire glomerulus will be involved. So if you want to take it, tell in a secondary terminology, from pathological points, few glomeruli are involved. Most glomeruli are involved. That's all. You can tell like that simply. Or segmental means a part of the glomerulus is involved. Global means whole glomerulus is involved. So I think now this terminology will make sense. So few glomerulus, most glomerulus, part of the glomerulus, whole glomerulus. So this is what we call as a segmental versus diffuse. So then there is another term in a proliferative pathology. There is something called a glomerular hypercellularity. There's one more term that you need to know, that's called a glomerular hypercellularity. So what do you mean by glomerular hypercellularity? This is a vague term. Whenever there's a glomerular hypercellularity, we don't know whether mesangium is proliferating or capillary is proliferating or parietal epithelial cell or visceral epithelial cell is proliferating. But nevertheless, whenever there is more than 100 nucleus per glomerulus, typically we call it as a glomerular hypercellularity. So these are some of the histological terms that we need to know before moving on to the actual glomerular disorders, which is very, very important. And we need to know about some of the pathogenesis. And I think a second year student should be able to tell, or anyone who completed the second year should be able to tell what is the pathogenesis, what is the pathophysiology of glomerular disorders. We need to know. So usually majority of the times glomerular disorders can be idiopathic if we don't know the cause at all, or it can be secondary. So whenever it is idiopathic, we call it as primary forms of glomerular disorders. Whenever there is a secondary form, we know there is some underlying cause. Straight away, there is an underlying cause, like infections or probably connective tissue disorder, like SLE. So there's some underlying cause will be there if it's a secondary. Primary means in general, it will be idiopathic in nature. We don't know what is the true underlying cause, which means there could be some antibody, but we don't know why that antibody is there. We don't have any underlying disease to explain that particular antibody that is seen in that particular glomerular disorder. So that is what we call it as idiopathic. And secondary means surely there will be some underlying cause. So the first thing that you need to know, most of the times, remember, as far as the idiopathic cause are concerned, you generally have some specific treatment. specific treatment may or may not be there. Usually immunosuppression. A blind immunosuppression is given whenever there is a primary disorder. Whenever there is a secondary forms of glomerulonephritis, you need to treat the underlying cause. So that is enough. So whatever is the underlying cause, you just treat that. Immunosuppression is not the primary treatment here, and immunosuppression is not even mandatory. For example, if there is a patient with HIV who get FSGS, you don't treat FSGS, you just treat HIV. And in that, if you start with the powerful immunosuppression like high dose corticosteroids, and patients going to get worse. So just treatment of the underlying cause, HCV related, cryoglobulinemia related MPGN, treat hepatitis C virus, that is more than enough. So you're just going to treat the underlying cause. You're not going to treat the patient with the high dose immunosuppression. So please understand that only in patients with idiopathic forms of glomerulonephritis, we usually go for immunosuppression. In patients with secondary forms of glomerulonephritis or glomerular disorder, we don't treat with immunosuppression, and we are going to just treat for the underlying cause. That's one thing that is very, very important. And no matter what, there are some specific pathogenetic factors that happens in either a primary or a secondary glomerular disorder, doesn't matter. There is some specific pathogenetic factor is there, which can affect primary or secondary glomerular disorder. So what are the specific pathogenic factors? It is nothing but an immune injury usually. So some forms of immune injury will be there in any patient with a glomerular disorder. So that is very important to understand. As far as immune injury is concerned, I mean, you would have studied in second year, there is one, I think, one table. I've studied Robbins like multiple times in my life. So one of my favorite textbook is Robbins more than Harrison. So if you take one characteristic table in Robbins that is given, and even Anderson pathology, if you take, there is one characteristic table that is even more elaborate and will be extremely good. 2 pages full table will be there in Anderson pathology. But nevertheless, if you see any forms of immune injury, they would have given that it could be either an antibody-mediated injury, or other forms of injury. So that's how I divide generally, because I feel this antibody-mediated injury is going to be the most important as far as the glomerular disorders are concerned. So whenever you take this other forms of injury, it could be due to either cell-mediated immunity. There are many evidence that T-cell mediated immunity plays a very important role in glomerular damage. So we don't want to discuss in detail, which is beyond the scope of the particular session. But nevertheless, T-cells are also very important in a lot of glomerular disorders. Even membranous minimal change disease, they believe that T-cells are the primary role in causing the minimal change disease. But even though that is not substantiated that nicely. And second, we have complement activation. That is also very, very important. In majority of the glomerular disorders, complement activation plays a very important role. But as far as the antibody-mediated damage is concerned, it's predominantly due to immune complex deposition, because most of the glomerular disorders will have some underlying immune complex deposition. It's usually due to immune complex deposition. As far as the immune complex deposition is concerned, we have different forms like something called a fixed or in situ immune complex deposition. In situ immune complex deposition. And second one, we have something called as a circulating immune complex deposition. Circulating immune complex deposition. As far as the in situ immune complex deposition is concerned, in situ means we know it is present in the glomerulus itself. Circulating means there is some circulating immune complexes that gets filtered by the glomeruli, and they get deposited in the glomeruli, thereby eliciting an inflammatory reaction. So this is what we refer to as a circulating immune complex deposition. In situ means there is some immune complex that is deposited in situ, that is present within the glomerulus itself, which means the antigen-antibody reaction happens within the glomerulus that subsequently forms immune complexes. Circulating means there is some antigen-antibody reaction that is happening elsewhere that is carried by the blood into the glomerulus, where it gets filtered and gets deposited. That is what we call as a circulating immune complex deposition. In situ immune complex deposition typically happens in another 2 ways. So one is called a fixed intrinsic antigens, which means these are type of antigens that are present within the kidney. And second one, we have something called a planted antigens, in the sense like there is antigen elsewhere that comes to the kidney and gets deposited there and then elicits a antibody reaction, where antigen antibody forms in the kidney. It's an in situ immune complex formation, and that causes the damage, which means, but the antigen is coming elsewhere, or antigen is present within the kidney, is what we refer to as fixed intrinsic antigens versus a planted antigens. As far as fixed intrinsic antigens is concerned, one classic example is there. That is the NC1 domain. This is a non-collagenous domain of alpha 3 chain of type 4 collagen. So this acts as an antibody. If you remember, the collagen has a collagenous domain and non-collagenous domain. So there are some non-collagenous domain. So like NC1, that's NC stands for non-collagenous domain of alpha 3 chain of type 4 collagen, which is typically present in the basement membrane. We know that. So this could serve as an antigen, and of course this is going to result in the development of an antibody called anti-glomerular basement membrane antibody. Remember, if anti-glomerular basement membrane antibody is going to produce only kidney disease, only kidney involvement, that will not be called as Goodpasture syndrome. As I told you already, it will be called as anti-GBM antibody kidney disease. That's all. That will be called as anti-GBM antibody kidney disease. Suppose if it's going to cause systemic involvement also, which means they are going to affect kidney plus lung together, that will be called as Goodpasture syndrome. Please understand, only if it affects kidney and lung together, you will be calling it as a Goodpasture syndrome. Otherwise, you won't call it as a Goodpasture syndrome. And apart from this non-collagenous domain, you have one more important intrinsic antigen. So what is the other important intrinsic antigen that is important for exams? That now the question is for the audience. What is one more antigen that can act as a intrinsic antigen that cause an important disease? Okay, let me tell. So that is the phospholipase A2 receptor. Clear? So this is very important for exam. So there are so many antigens are there. It is not that there are only one or two antigens which I'm going to tell here, Keshav. So many antigens are there. The idea is to know what is clinically relevant. So that is what is important. So remember, we have tests that can detect the anti-GBM antibody, and we have tests that can detect the anti-PLA2 receptor antibody. Anti-plateau receptor antibody. See, this anti-PLA2, that is phospholipase A2 receptor antigen, is basically present in the foot pros of the podocytes. Foot pros of visceral epithelial cells. So visceral epithelial cells is what we refer to as podocytes, and it's present in the foot pros of podocytes. And you can develop antibodies against this PLA2 receptor, and especially the M type of the PLA2 receptor. So it's called not just the usual PLA2 receptor, that's called a M type PLA2 receptor. So against which antigens are typically formed, called as anti-plateau receptor antibody, which is extremely important for one important disease called as membranous glomerulonephritis. So here I told you how it's important for developing this Goodpasture syndrome and anti-GBM antibody kidney disease. For membranous glomerulonephritis, this anti-PLA2 receptor antibody is extremely important. So number two. And apart from that, you have multiple mesangial antigens, and you have multiple other antigens like what you told, megalin and phospholin. So many antigens are there which are not important for our clinical understanding or even not important for your exam. So this is the two antigens that usually they will be asking you in exam. As far as the planted antigens are concerned, planted antigens can be exogenous in nature or it could be endogenous in nature. So exogenous means it's coming from outside the body. Endogenous means that is present within the body. Exogenous typically will be infectious antigens, which means some bacteria or virus or probably some drugs, for example, like heroin, which can cause problems, like D-penicillamine. So many drugs can produce, like not only virus, even malaria, Plasmodium malaria species can cause nephrotic syndrome, typically a MPGN type of nephrotic syndrome, which we'll be discussing later on. And at the same time, you have some endogenous antigens that can get planted in the kidney and thereby eliciting an immune reaction, locally forming in situ complexes, like a DNA, which can happen in SLE. Correct? So DNA from elsewhere can be detached because of the damage done by SLE antibodies, and that DNA can get carried and they can be planted within the glomerulus, resulting in the formation of in situ immune complex formation. So DNA, then immunoglobulins, nuclear proteins, immune complex IgA. So many things can get deposited in the kidneys and can act as a planted antigen. So then coming to the circulating antigens, circulating immune complex deposition. So as far as the circulating immune complex deposition is concerned, once again, I can split into exogenous immune complexes and endogenous immune complexes, exogenous and endogenous. As far as exogenous is concerned, once again, it's going to be infections as very commonality and could be drugs, or circulating immune complexes can be formed by DNA and tumor antigens. So again, the best example for DNA acting as a endogenous antigen is SLE. We know that where you form anti-dsDNA antibodies, and if you want to know the second example, tumor antigens causing this glomerular disorder is probably a solid organ tumor or even a hematological cancer like lymphomas, which can cause glomerular disorders. For example, solid organ tumors typically cause two important problems. One is membranous glomerulonephritis, and second is minimal change disease. And hematological tumors typically result in development of minimal change disease, or MPGN sometimes. So we do know that these tumors are associated with development of glomerular disorders, in that both solid organ tumors as well as hematological tumors can serve as antigens. These tumor antigens can be planted with, can circulate, and they can produce some immune complexes elsewhere that can get trapped and deposited in the glomerulus, so which is pretty important as well. So fine. So these are the different forms of immune-mediated injury that happens in the glomerulus. This is the pathophysiology of the entire glomerular disorder, which is very important for understanding as well. Apart from this, what else is important? So I need to know that is there any specificity for this immune complex deposition? I told you a lot of glomerular disorders are basically happening due to immune complex deposition. Is there any specificity for a particular location? So for example, these immune complexes, you think they have specificity for subendothelial region, or they have specificity for subepithelial region, or they have specificity for mesangial region. So do these immune complexes have any specificity for getting deposited in particular area? Yes or no? Question is yes, or I think you can understand my question. That's why I asked this question. Actually, answer is no. They don't have any specificity. Absolutely, these immune complexes that are circulating do not have any specificity for getting deposited in the subepithelial region or subendothelial region or immune complex, mesangial region or within the base membrane. Absolutely, they don't have any specificity. Then how come certain complexes are in the subepithelial region, certain complexes in the subendothelial region? How come this happens? So that is basically not related to the type of immune complex, that basically depend on the physicochemical properties of the immune complexes. The physicochemical properties of the immune complexes is the one that determines where they should get deposited. It's not that SLE means it will be subepithelial, PSGN means they produce subepithelial humps, and this disorder like MPGN means subendothelial. It's not like that. It's just the physicochemical properties that's going to determine whether they should be deposited in the subepithelial area or they should be deposited in the subendothelial area. For example, if the complexes are highly cationic in nature, they will cross the base membrane very easily. But because we know that base membrane is mostly negative charged, we know the reason, and there are multiple molecular reasons behind why the base membrane is negative. And we have, I should have actually drawn the base membrane in pink, isn't it? So that's the right color. And we have the capillary endothelium with fenestrations, and we know that. So this is the endothelium that has fenestrations like this. So I can draw the endothelium like this. So this is the capillary endothelium that has fenestrations. And we do have the podocytes, like we can tell the foot process of the podocytes like this as well. Let us assume these are the foot process of podocytes. And we know very clearly that this base membrane is basically negatively charged, and they are more anionic in nature, right? So that is why whenever the cationic components are there, whenever the immune complexes are more cationic in nature, they are more positive charged. It's very easy. Suppose if you have immune complex which is having positive charge, they are going to move easily out of the base membrane, which means this negative charge will attract and they easily cause damage to the base membrane, and they move out of the base membrane, and their typical location will be in the subepithelial region. Typically, they produce subepithelial deposition. It all depends on the physicochemical properties, not because they have some specificity towards a particular location. And similarly, if the immune complex are more anionic in nature, for that matters if they are negatively charged, so which means they cannot cross this base membrane and they repel out of the base membrane, and they typically have this subendothelial deposition underneath the endothelium, which means they'll be deposited in this area, subendothelial, because they're more anionic in nature. And number 3, if they are neutral, they don't have any net positive charge and net negative charge. If they are neutral in nature, they will produce this kind of mesangial deposits. So which means there is no any particular specificity for a particular disease to produce immune complex in that particular area. It all depends on the physiochemical properties. But most often, for our basic clinical understanding, we tell that PSGN means it's subepithelial, like your membranous nephropathy means it's subepithelial, and again membranoproliferative means it's subendothelial. But nevertheless, we don't have any, the disease doesn't have itself any particular specificity for producing any immune complex in a particular location. So this is the reason why you get certain particular deposition. It all depends on the physicochemical properties, and again given beautifully in Anderson's pathology. And these are typical straightforward words that is given in that particular location. And what is the size of the endothelial fenestration? So can anyone tell what is the size of the endothelial fenestration and what is the size of the filtration slit? So this gap between the two vessel epithelial cell is what we refer to as filtration slit, or we call it as a urinary slit. And what is the size? So first let us start with the fenestration. So what is the size of the fenestration? Any idea? Endothelial fenestration, yes, 50 to 100, but most of the textbooks give 70 to 100 nanometer. That's the right answer. And what about the filtration slit that is present, the gap that is present between the two vessel epithelial cells, between the two food process of, not two vessel epithelial cells, between the two food process of podocytes? That is the urinary slit. This is more important compared to that. It's 20 to 30 nanometer. 20 to 30 nanometer is the size of the filtration slit. So these two numbers may be important for exams, but I don't know, one-liners, how much it's important right now, I don't know. And there are a lot of cells that are also important as far as the third point that we need to know is first thing I told you the immune complex nature, and second thing I told you the physiochemical properties, and third thing we need to know about the cells that are important. So a lot of cells that can infiltrate the glomerulus. One is the neutrophils. And of course, neutrophils can produce so many problems, and neutrophil infiltration is very commonly seen in acute forms of glomerulonephritis. In acute forms of glomerulonephritis, neutrophil infiltration is quite common. They can produce a lot of effects like glomerular base membrane degradation. How they produce GBM degradation? By producing a lot of variety of proteases. They can cause GBM degradation. They can produce cell damage, direct cell damage, because they produce a lot of free radicals, we know that. And at the same time, they can reduce the GFR by themselves. How they can reduce the GFR? Two reasons. One, by plugging the glomerulus. Of course, when they come into the glomerulus, so we have an afferent arteriole, we have an efferent arteriole, and we know we have the glomerulus, for example, here. And this afferent arteriole forms capillary loops, and they are the ones that are going to form the GFR. Suppose if this neutrophils come and plug the afferent arteriole and they plug the glomerulus, which means there are too many cells, and the amount, the pressure that is required for producing an effective filtration is less, and they plug the afferent arteriole, they plug the glomerulus, and the urinary space will reduce. Because of that itself, they can reduce the GFR, point number one. At the same time, they can produce arachidonic acid metabolites. So a lot of arachidonic acid metabolites can be produced by this PMNs. That itself can result in the reductions in the GFR, like thromboxane A2, maybe less prostaglandin I2. So these are some of the reasons why they can reduce the GFR, and that's also the reason for acute kidney injury that is seen in some acute forms of glomerulonephritis in the first place. Second, macrophages and T cells, very, very important. And lot of importance of macrophages and T cells are there. They themselves can activate B cells, resulting in more production of local antibodies that can produce more immune complexes. So that's separate terminology. And platelets can get deposited. That is because of endothelial injury once again. Whenever there is an endothelial injury caused by these inflammatory cells, there will be local platelet activation and platelet deposition. And platelet deposition can result in production of many other derivatives like eicosanoids, and they can also plug the glomerulus, reducing the GFR. Eicosanoids, growth factors like PDGF, which can result in fibrosis over a period of time, and many other mediators as well. And substantial numbers are there, so you don't want to tell. And mesangial cells. Mesangial cells are like reticuloendothelial system of the kidney. We know that they are actually forming the monocyte macrophage system in the kidneys. So we know where the mesangial cells will be there. It will be in between the glomerulus, between the capillary loops. You will have these mesangial cells. Usually 1 to 2 mesangial cells is the maximum. Anything more than 2 in a particular glomerulus means mesangial proliferation or mesangial hypercellularity in a glomerulus. So mesangial cells are very active cells. Basically, if they are activated, they can perform the same function as the monocyte macrophage system. They can release reactive oxygen species. They can produce cytokines. They can produce endothelin. They can produce nitric oxide. They can produce various growth factors. They can produce chemokines, and they itself can induce a lot of damage. So these are the cells that are important. And number 4, finally, we are going to end up with the mediators. So what are the mediators that are important and essential for producing this glomerular injury and glomerular damage? First one is the products of complement activation, complement mediated, complement dependent proteins or complement related proteins. The C5a is going to be the most, C5a is going to be the most important, which serves as an important anaphylotoxin, and that is important for influx of the inflammatory cells to that particular area. I think this is something very basic hematology. So C5a is an anaphylotoxin, and it's a chemokine, and itself can drag the inflammatory cells towards that particular area wherever it is getting produced, C5a. And we have C5b to C9, which is very important to produce this membrane attack complex or terminal attack complex that causes cell lysis in the local area. And at the same time, they can stimulate the mesangial cells as well. The complement related mediators can stimulate the mesangial cells as well. And there are various cytokines that also cause damage, and the significant cytokines that cause damage is interleukin-1 and tumor necrosis factor alpha. These are the 2 cytokines that are very, very important. At the same time, variety of chemokines are there. Among the chemokines, if they ask you one important chemokine that is very important is MCP1. So this is important for your multiple myeloma also. If you take the multiple myeloma chapter and see, this MCP1 is very, very important for producing this typical osteolytic lesions that you see in patients with multiple myeloma. On the other hand, this is also important for glomerular injury and glomerular disorders, especially RPGN and all. This MCP1 becomes a very important thing. That is monocyte chemoattractant protein 1. You would have studied in multiple myeloma. Go back to your pathology textbooks and you can see in multiple myeloma as well. And we have variety of growth factors that are important, as I told you before, in that the PDGF is very, very important, which comes from the platelet-derived growth factor, where it is going to typically result in mesangial proliferation. And we have TGF-beta, which is a very important fibrogenic factor. This is the one that is responsible for producing this hyalinization, this matrix deposition, hyalinization. I think the spelling is right. Wrong. The hyaline deposition and glomerular sclerosis is all dependent on this TGF-beta only, which is a very important growth factor. And VEGF. VEGF is very important because this can result in capillary proliferation, so which is also a feature of a nephritic syndrome. We know that endocapillary proliferation, which is seen in SLE also. Because of the capillary proliferation only, SLE, you get something called this wire loop lesions, which I told you already. So VEGF is also a very important factor. And apart from that, the coagulation system, thrombin and fibrin are very important because this is the one that glues the parietal epithelial cells together and very important for formation of crescents. Even though crescents are basically formed by proliferation of the parietal epithelial, parietal epithelial cells, but they are basically glued together in between by certain platelets and thrombin, which is very important. So thrombin is the one that basically stimulates the formation of crescents, and that's a very important point to note. Really, really important in exams. Fine. So these are the entire pathophysiology. So there are certain few things that you need to know for exam: C5a, then MCP1, PDGF, TGF, beta, and VEGF and thrombin. Very, very important. Each and everything has its own clinical relevance as well as pathological relevance. So these are the pathophysiological features of glomerular disorders. So if you have understood this, let us move on to the next topic. Do you understand these pathophysiological features? Yes, cool. So if you have understood, then let me ask you one question. So what are the differential diagnosis of flea-bitten kidney in the exam? In exam, if they ask you something called a flea-bitten kidney, so what are the 3 differential diagnoses? You have 7 to 8 that is given in Anderson's pathology, but 3 differential diagnoses important for exams. So one thing you will tell very easily. I know, yeah, straight away Keshav is telling malignant hypertension. But I don't really call it as a malignant hypertension, but we typically tend to call it as something called a malignant nephrosclerosis. Remember, flea-bitten kidney is basically gross pathological finding where there will be small spots of hemorrhages as if they are bitten by a flea. But and because of it's a pathological finding, even the explanation also should be from the microscopic point of view, from the histological point of view. So you should not call it malignant hypertension. Rather, I will call it something called a malignant nephrosclerosis. So that's the right terminology rather than using a malignant hypertension. So number 1. Second, not IgA nephropathy. IgA nephropathy can, but I mean indirectly, not directly. Second is RPGN. That's what I need. So in glomerular disorder, that is rapidly progressing glomerulonephritis. Number 2. Number 3. Anyone? No, not PSGN. Okay, I'll come back to that. So why you are not Polytis nodosa as well, not HUS, but I mean whatever you are telling are basically like are just extrapolations of PSGN. So what you didn't understand that one particular fact is that you are confusing that RPGN is a separate diagnosis. Where is that RPGN? Discuss something called RPGN. You are thinking that RPGN is a separate entity. No, RPGN is not a separate entity. Any nephrotic or nephrotic syndrome can produce RPGN. It's not like RPGN means it's RPGN only. It will not interfere with other. For example, an SLE can produce RPGN. If it's severe enough, it can produce RPGN. If it's very severe enough, they can come with acute glomerulonephritis. If other conditions like PSGN, if it's severe enough, can progress towards RPGN. If IgA nephropathy is severe enough, they can progress to RPGN. So RPGN, clinically, we just called as a type of severity. That's all. It doesn't matter. And which is more severe? I feel like among these 3, RPGN is more severe. Why? Because AKI, you will be able to see what's happening. AKI, the patient will come very fast and you will be able to do something, dialysis. You will be able to reverse the underlying cause. You will treat it very fast. So you have some cushion for treatment. So even though the patient comes with an acute kidney injury, you do dialysis, you start treatment aggressively, reverse the cause so that the kidney might get better. Chronic glomerulonephritis, again, you don't do anything because by default, whenever the patient is coming with a chronic glomerulonephritis, you understand the nature of the disease, that it is very slow. Number 1, we know that it is going to be very slow. There's no doubt about that if it's going to be a chronic glomerulonephritis. And by definition, it's going to take a long time for progression and you're going to treat like a CKD. So by definition, it is very slow. This RPGN is somewhere a problem because patient will not have much symptoms initially. And by the time they come, there will be a substantial kidney damage. So it's very difficult to reverse the underlying problem also. At the same time, you have to cut down the progression towards CKD also. So that is the reason why these crescents are very dangerous, because that indicates a pretty long-term kidney injury, like over weeks it's happening. It's cooking over time. At the same time, it's well cooked also. So which means you cannot just take away and throw that as well. So it's very difficult to reverse as well. There's a lot of chance for progression towards CKD also. And the disease also tells that it's rapidly progressing, which means if you leave a little bit also, the creatinine, which has doubled in 6 weeks, it will become double in another 6 weeks. And slowly within a few weeks, the patient will die over a period of time. So I believe that RPGN diagnosis or RF diagnosis is going to be really, really important as far as clinical understanding is concerned, because that is the one that kills the patient usually. Because nephritic AKI, if they come like AKI, they don't kill because we know what is the cause. The patient will come dramatically 1 or 2 days. We reverse the problem and we send the patient home within a couple of weeks. CKD, like it's default slow and it's going to take a long time for worsening, and dialysis, so many options are there. RPRF is something the patient also doesn't know. The doctor needs long time of assessment. We don't know what the underlying cause is. So the RPGN is more problematic most of the time. That's going to kill the patient. That's what we need to know. But nevertheless, remember, RPGN beginners' problem is they understand that this is a separate disease. That's what they think about. But actually, RPGN is basically not a separate disease. RPGN is basically a disease that is severe enough. So any disease, even SLE or IgA nephropathy or PSGN or any other condition that is severe enough, can produce a rapidly progressing glomerulonephritis. That is very, very important to know. Okay. Coming to our original question. What is our original question we started with? Okay. What are the differential diagnosis of a flea-bitten kidney? Flea-bitten kidney, this is what I thought. So one diagnosis I told you, it is RPGN. That's the most important according to me. And second differential diagnosis is, that malignant nephrosclerosis. This is what the right term is, not the malignant hypertension. And number 3, you have that this thing, infected endocarditis, bacterial endocarditis, infected endocarditis. So this is the 3 important differences, especially subacute. Bacterial endocarditis produces more risk of developing this flea-bitten kidney compared to the acute forms of infected endocarditis. So infected endocarditis. These are 3 important terminologies that you need to know whenever you encounter a term called flea-bitten kidney in the exam. Clear? All right. So there are a few situations. So now you need to know what are the conditions that produces renal limited diseases. There are a few glomerular disorders that will be renal limited in nature. And there are a few glomerular disorders that are systemic in nature, which means they will have associated systemic manifestations as well. So what are the glomerular disorders that are renal limited? Number 1, we have something called infection-related glomerulonephritis. Typical example for infection-related glomerulonephritis is something called as a PSGN, post-streptococcus glomerulonephritis. So this is a disorder that is affecting only the kidneys as a major problem. You don't have cardiac problem or brain problem or other areas. Unless until patient develops a rheumatic fever, that's different. So we're not talking about rheumatic fever here. PSGN is an entity that produces only kidney problem. So it's post-streptococcus glomerulonephritis. That's an infection-related glomerulonephritis. And we have something called a membranoproliferative glomerulonephritis, typically due to hepatitis C virus, which affects only the kidney most of the time. And at the same time, we have something called other forms of glomerular disorders like fibrillary glomerulonephritis and immunotactoid glomerulonephritis, the details of which I'll be sharing in some time, because there is a separate type of glomerular disorders called glomerular disorders with organized deposits, in that amyloidosis, fibrillary, immunotactoid, collagenofibrotic. There are many different variants out there, which is very important to understand as well. Number 4 is IgA nephropathy, not enoxaparin purpura. IgA nephropathy is a very, very important condition that affects only the kidneys in reality. And there is something called a ANCA-associated renal limited vasculitis, ANCA-associated RLV, ANCA-associated renal limited vasculitis. That is also something that is going to also affect only the kidneys, not any other areas. But there are some systemic disorders that affect kidney as a part of their systemic involvement. The classic example we know, it is systemic lupus erythematosus. Nobody can forget SLE. SLE is something that can produce systemic manifestations apart from having only the kidney manifestation. And second is cryoglobulinemia. Cryoglobulinemia is something that has systemic manifestation apart from only kidney manifestation. I mean, this is where you get confused to call whether it's a cryo or HCV. Remember, HCV alone causing glomerulonephritis will be different. HCV causing cryo causing glomerulonephritis will be different. In both these situations, you will get MPGN type 1 only. So usually in exam, this is where you get confused. In both these situations, they're going to cause MPGN type 1. There's no doubt about that. HCV causing glomerulonephritis or HCV causing cryo, that is causing glomerulonephritis. Both are going to produce MPGN type 1 as a classical manifestation. But how will you differentiate in exam? If you have an underlying HCV, you have only glomerulonephritis. So that is MPGN type 1. Suppose if you have a HCV that has palpable purpura, arthritis, so many other manifestations of cryoglobulinemia is there, and that is producing glomerulonephritis, means this will be called as a cryoglobulinic glomerulonephritis, and that will have histological manifestation of MPGN type 1. So that is why in exam it becomes important to find out whether HCV related glomerulonephritis or HCV related cryoglobulonemic glomerulonephritis. Both are little different as far as the terminological perspective, but both are going to cause the same histological presentation, that is MPGN type 1. These are very, very small things that you need to know. Apart from that, I mean, this is where you get confused whenever you study the textbooks. But apart from that, other things are going to be well and very simple. And we know ANCA-associated vasculitis that are systemic in nature. I mean, I can write systemic ANCA-associated vasculitis. That will be the right terminology. Systemic ANCA-associated vasculitis, typically like vaginous granulomatous, they have ENT involvement, lung involvement, along with kidney involvement. Chooks-Strauss syndrome, lung involvement, asthma, cardiac, GIT, CNS involvement, along with kidney involvement. Microscopic polyangiitis, they might have lung involvement and many other organ involvement along with kidney involvement as well. So systemic ANCA-associated vasculitis and infective endocarditis, especially subacute bacterial infective endocarditis. And number 5, we have henoch-Schönlein purpura. Remember, usually IgA nephropathy or henoch-Schönlein purpura are going to be basically same. I think we have discussed this in the vasculitis session itself. If you have only IgA deposits that are destroying the kidney alone, that is called IgA nephropathy. If you have systemic vasculitis, MPGN type 1 cryoglobulinemia complement levels are elevated or decreased. It depends once again. So as far as MPGN is concerned as a whole, complement levels will be decreased because MPGN is a disease that is going to be due to complement activation only. So typically complements will be decreased in any condition. But remember, whether complements are decreased or increased, again, it does not depend on a particular disease. It depends on what is the nature of the immune complex. Where is that? What is the nature of the immune complex? Not just the physiochemical properties. At the same time, what is the immunoglobulin composition and what is going to be the location of the immune complex? All these things are going to determine whether the complements will be decreased or increased. For example, if it's an in situ immune complex deposition, typically this is a predominant thing, then complement changes will be very little because these immune complexes are formed in the subepithelial region only, and they're not moving elsewhere in the blood. So activation of the complements will be very poor. And in the sense, only localized activation of complements may be there. And the complement levels may not change that much. On the other hand, if you have a circulating immune complexes, you might have a change in the complement. So which means these immune complexes are in the blood and they're going to activate complements wherever they go in the blood. So your fall in the complements will be much more severe if you have a circulating immune complexes like SLE or probably a tumor, rather than or an infection, a diffuse infection, rather than having an in situ immune complex like anti-GBM antibody or probably a plateau receptor antibody or anti-GBM antibody. So in these conditions, the complement levels may not change that much. So because these are in situ, on the spot immune complex formation, so they're not going to change the complements that much. So, and again, it depends on the type of the antibody as well. For example, if it's IgM predominant, so they're going to affect the complements very badly. On the other hand, if it's going to be IgG, they can activate the complements to some extent. But if IgA, they are extremely weak activators of complement. So IgA nephropathy typically, again, even though you can have a systemic IgA that is circulating, they don't generally activate complements that much. So the complement levels will not change that much in IgA nephropathy. So it just don't depend on one particular factor. It depends on a variety of factors that can affect the systemic complements. But ultimately, I'll tell you the nutshell, which are the diseases that will change the complement, which are the disorders which will not change the complement. But nevertheless, it depends on multiple factors. That's what you need to know. But as far as Harshini's question is concerned, MPGN 1 will cause elevated or decreased complement. I'll go for decreased complements. That's my usual understanding. Suppose let us start with IRGN, that is infection-related glomerulonephritis, that is PSGN. So what is the typical? This is for the exam purpose. So if you study this table itself, it's going to be more than enough. So usually there will be history of pharyngitis will be there, sore throat will be there. So I can write some streptococcal infection or sore throat is there. Both stands for ST here. And the patients will have elevated ASO titers and the patients will have reduced C3. This is a very important point. So this is what is going to be the typical nature of an infection-related glomerulonephritis or a post-streptococcal glomerulonephritis. As far as membranoproliferative glomerulonephritis is concerned, typically the patients will have reduced C3. That's very important in membranoproliferative glomerulonephritis. And many of the patients might be having history of HCV infection or HBV infection or HIV infection. And fibrillary and immunotactile glomerulonephritis will have a normal C3 and C4. And as far as IgA nephropathy is concerned, once again, the patients will be having a normal C3 and C4. and the patients might have an elevated IgA, increased IgA, but this is optional. May be there or may not be there. And as far as the ANCA-associated vasculitis is concerned, typically they will have a normal complements, normal C3 once again, and there will be no immune complex deposition, which means immunofluorescence will be negative. That is very classic of a ANCA-associated vasculitis. So if SLE is concerned, SLE, we know you're going to have a variety of antibodies. Very easy to find out in this situation. They're going to have a positive ANA or an anti-dsDNA. And at the same time, they will have a reduced C3 and C4. Reduce C3, C4. Remember, this anti-dsDNA is very, very important. There are two antibodies that cause kidney damage in SLE. One is anti-dsDNA and anti-C1q antibodies, which I've told you that anti-dsDNA is the commonly encountered antibody. Whenever the patient is negative for anti-dsDNA, they're unlikely to have kidney disease. Whenever they have very high titers of anti-dsDNA, they are going to have a very bad kidney disease in that patient. As far as cryoglobulin is concerned, typically the blood will be positive for cryoglobulins. That's very important. There's something called a cryocrit, which I have not discussed, but that's very important. Cryoglobulins will be positive. Patients will have a positive rheumatoid factor as well. And at the same time, usually it is associated with hepatitis C virus. And the patient will have skin manifestations like palpable purpura, which you need to find out. At the same time, patients will have a low C3 and low C4 as well. So this is what is going to happen in cryoglobulin. Then systemic ANCA-associated vasculitis, once again, same thing. They're going to have normal complement, C3 will be normal, and at the same time they will be having a negative immunofluorescence. That is very important to note as well. As infective endocarditis is concerned, typically the patient will be having underlying valvular disease. Most often in exam, that will be the clue. Patient having underlying valvular disease. Along with it, if the patient gets an AKA or a kidney disease or hematuria, think about an infective endocarditis related problem. And at the same time, they might be having positive blood cultures as per the Duke's criteria, which I've discussed already. So these are the clues. And once again, they'll be having a low C3 levels. And as far as HSP is concerned, typically they will be having features of IgA nephropathy, plus they will be having vasculitic picture, which you have discussed already. If IgA nephropathy alone means that's called Berger disease, that's IgA nephropathy. If you have systemic vasculitis associated, especially in children and adolescents, that is called an enoxaparin purpura. So for example, they will be having a palpable purpura, gastrointestinal tract involvement like abdominal pain, GI hemorrhage can happen, or the patient might be having joint involvement, musculoskeletal involvement like arthralgia and arthritis. So typically, once again, what are the phases of IgA nephropathy? They'll have a normal C3. At the same time, they might be have a elevated Ig levels. This is an optional one, elevated Ig. So these are the features of enoxaparin purpura. In exam and in reality, finding out a particular disease is actually very, very easy. But it's just we used to complicate a lot of stuff. So actually finding out a disease is much, much simpler, not a big deal at all. So you have a lot of variety of clues in front of you most of the times in real patient. So it will be easily, you can find out what is a probable diagnosis that the patient is having. But nevertheless, remember one important thing to notice that this glomerular disorders are a diagnosis of biopsy only. There is no doubt about that. So whenever you talk about the word glomerular disorders, you can diagnose only by biopsy. The only gold standard is biopsy. Without kidney biopsy, you cannot do anything. So you cannot diagnose any of the glomerular disorders. So it is always the biopsy that is the gold standard key point here. So that's going to tell you the real diagnosis in a particular patient. Okay. So if you understand this table, we can move to the next one. Do you understand this? So whatever I've told you. Yes. Okay, let us move on to the predominant nephritic disorders first. So what are the predominant nephritic disorders? We start with IgA nephropathy. IgA nephropathy to start with. I mean, these are primary nephritic disorders. So IgA nephropathy is most often a primary nephritic disorder, but it can be secondary sometimes due to underlying vasculitis. But typically IgA nephropathy is primary. If it's primary, we are going to call it as a Berger's disease. This is what is very important. At the same time, IgA nephropathy can be secondary also. Secondary due to underlying vasculitis. due to underlying vasculitis, and we know what the vasculitis, that is henoch-Schönlein purpura. And apart from that, you might have in variety of other disorders without underlying vasculitis, other disorders. Like for example, you can get with some skin problems like psoriasis or dermatitis herpetiformis, or some gastrointestinal problems. What is a similar disease to dermatitis herpetiformis that happens in the stomach? I mean, that happens in the GIT. You know that. So dermatitis herpetiformis, the basic idea is gluten hypersensitivity. So you're going to get celiac disease here. Of course, we know that. So GIT, celiac disease, that's very important. And yes, it can happen with IBD as well. Deposition can happen with IBD as well. So inflammatory bowel disease. And certain rheumatological disorders can produce IJ deposits in the kidney. So it could be with ankylosing spondylitis. Don't think aortic stenosis. I'm writing about ankylosing spondylitis, SLE, rheumatoid arthritis, Sjogren, cryoglobulinemia. All these things can produce IJ deposits in the kidney. And there are various other connective tissue disorders, like not various other connective disorders, like I can write other disorders like maybe cystic fibrosis sometimes. Cystic fibrosis, then it can happen with vaginous granulomatosis, or it can happen with sarcoidosis. So these are some of the examples, but please understand the fact that only in these two conditions, that is Buerger disease and henoch-Schönlein purpura, they are going to have kidney damage due to IJ deposits. Kidney damage due to IJ deposits. So only in these two conditions, they will be having kidney damage due to IJ deposits. But whereas in other conditions, either the kidney is not damaged, or the kidney might be damaged, but it's not due to IJ deposits. Kidney damage is not due to IJ deposits. Okay, so this is a very important point. So why only in these two conditions? For example, you have this, isn't it? So Buerger's disease and HSP, only in these two conditions, the kidney damage happens due to IJ deposits. So there has been a considerable research that is going on in this particular setting. But we believe that both these disorders are similar because both these disorders will have a history of URI prodrome very commonly. And after this history of URI prodrome, they are going to develop glomerulonephritis. This is what is going to happen. So if you have only glomerulonephritis, that is IJ nephropathy, along with that, if you develop a systemic vasculitis, we are going to call it as a henoch-Schönlein purpura. Both are IJ related disorders. Plus at the same time, one is producing extra vasculitis, one is not producing vasculitis in the first place. So this is the only difference between the two. Apart from that, both are basically having a characteristic background URI prodrome, then followed by a glomerulonephritis and a vasculitis. I mean, may or may not have a vasculitis depending on what is the disease. So typically IJ nephropathy is a disorder that is seen in adults, and henoch-Schönlein purpura is something that is seen in children and adolescents. Children and adolescents very commonly. Children and adolescents. This is what is happening here. So, which means what we are actually seeing is a same disease, but with a different spectrum of manifestations. For example, a patient who's a child develops a probable infection, we don't know whether this URI prodrome is a prodrome of this disorder, or is it due to some infection, we don't know. There are a lot of infectious agents that have been postulated nevertheless, but there could be some underlying infection where certain children and adolescents behave differently in the form of henoch-Schönlein purpura, but adults behave differently in the form of IJ nephropathy. So that's the current understanding about IJ nephropathy and henoch-Schönlein purpura, but nevertheless, this is the idea. So which means if these two are only producing IJ nephropathy which means they are only producing kidney damage, means they should be having some underlying problem as well. So what is the reason why they have to develop this IJ nephropathy? So that is due to the immune dysregulation. That's the hypothesis that is made. That's called the immune dysregulation hypothesis, especially of the B cells, typically due to something called a B cell mistrafficking. B cell mistrafficking. That's what is going to happen. So what do you mean by a B cell mistrafficking? Because in our body, we have different types of IgA molecules. We have IgA1 type, we have IgA2 type, we have many different types of IgA. So for example, if you take an IgA molecule, you can have a mucosal form of IgA, or you can have a plasma IgA. If somebody asks you in the body which is going to be the maximum number of antibody that is synthesized per day, I'll always go for IgA only, because IgA is the one that is maximally synthesized in the body per day because it's a mucosal antibody. Imagine the mucosal surface from mouth to the anus and from the nose to the entire respiratory tract. Everywhere IgA is produced. So IgA is the antibody that is produced in maximal amount in the body per day. It exceeds any antibody by a huge margin. So IgA is a very, very important antibody. The most important antibody I believe is IgA only, because the first entry point of any organism is through the mucosal route only. So that's really, really important. So then followed by IgG. But in the blood, if you take IgG is the predominant. So, first IgG, then IgA, then IgM. So you have studied that. So IgG is the predominant antibody in the blood. But in mucosa, IgA is important. The whole body IgA is going to be more important. So nevertheless, we have two different forms of IgA. In mucosal IgA, and you have something called a plasma IgA. Whereas mucosal IgA is typically IgA1 type. Usually, this is the one that forms something called as a secretory form of IgA. You would have studied in your pathology, or probably even in your microbiology, you would have studied that forms a secretory IgA, where there will be two IgA molecules that will be combined together, and together they will be attached with a secretory chain, a J chain. Additionally, they will be combined with a J chain, that is different. Additionally, they'll be having some secretory chain as well. So this is the typical view of how a mucosal IgA looks like. It's dimeric in nature. As far as the plasma IgA is concerned, it will be of mostly IgA2 type, which will be usually monomeric in nature. And this is a secretory IgA, which will be dimeric in nature. And at the same time, there are certain patients with secretory IgA that will be having something called a galactose deficient. This is called a GD, galactose deficient hinge region. Whereas this IgA2 does not have galactose deficient hinge region. Does not have this galactose deficient hinge region. No galactose deficient hinge region as far as IgA2, monomeric IgA is concerned. But mucosal IgA typically has this galactose deficient hinge region, but that has to be seen only in the mucosa. What really happens is, because of the B cell mistrafficking, these patients will have mucosal IgA in the blood. So there will be entry of mucosal IgA in the blood, which means IgA1 that is having this galactose deficient hinge region due to some unknown reasons, which means that is due to the immune dysregulation that is happening in the background, that is due to B cell mistrafficking that produces IgA1 that enters the blood from the mucosa, which means the B cells are mistrafficked. They are producing IgA1 in the blood unnecessarily. And this galactose deficient hinge region is acting as an antigen, and they are going to produce antibodies against this galactose deficient hinge region. You will start developing antibodies against this galactose deficient hinge region of IgA1. So what is going to happen is, you will have an IgA1 molecule that is having this galactose deficient hinge region. Along with that, you are going to produce antibodies that will be direct against this particular hinge region. That's what you're calling about. This hinge region is galactose deficient, and that will be recognized antigen, and they are going to produce antibody against this galactose deficient hinge region, which will be typically of IgA type, or it can be of IgG type also. The antibody that is formed may be of IgA or IgG type, but it is actually formed against this IgA. So that's a very important question in exam. They will be asking you, this IgA1 is the one that is often referred to as a nephritogenic IgA. IgA2 is basically not a nephritogenic IgA, and IgA1 is a nephritogenic IgA. Why it's nephritogenic? Because it has galactose deficient hinge region. By some chance, because of B cell dysregulation and mistrafficking, if it enters the blood, they're going to produce antibodies against this hinge region that is galactose deficient, and they result in formation of antigen antibody complexes. And this antigen antibody complexes is going to get deposited in the kidney. And more importantly, in the pathophysiology, I didn't tell one point. So it will be the large complexes that will be deposited or the small complexes that will be deposited. Tell me. So which will be deposited in the kidney? So large complex will be deposited in the kidney, or the small complexes is more prone for deposition and damage in the kidney. Which will get deposited and which is going to cause more damage. Nobody is answering, right? So large or small? No, actually, it's not the large. It's a small complex that are more problematic. It's not the large complex that are problematic, because large complexes are easily filtered and destroyed by the reticular endothelial system. Macrophage itself will engulf the large complex, but these very small complexes, most of the time they escape and they go through these fenestrations and all these things, and they get deposited in different areas. So this large complex are the problem. Sorry, small complex are basically the problem and not the large complexes. So these are typically small complexes, IgA. At the same time, the serum complements in IgA nephropathy will be normal. Why? Because I told you IgA will not activate complements that much. But when you study the histology, they will tell C3 deposition will be there. I mean, you will be like bamboozled. So why patients should have normal C3 in the blood, but in the kidney, if you take a biopsy, there will be C3 deposition. These are some usual questions that a second year candidate or a final year candidate generally gets. The reason is very simple. IgA is not enough to you need a high concentration of IgA to actually activate the complements. IgA is not that much eligible to activate complements. Usually the best activator of complement is IgM, then followed by IgG, then followed by IgA. IgD and IgE does not activate the complement at all, but one of the weak activator of complement is IgG. In the circulation, IgA concentration will be very low. In reality, this IgA1 concentration, that's what I'm talking about. This nephrogenic IgA1 concentration will be very low. They'll not be able to activate complements globally. But once they get filtered out in the glomerulus, their IgA1 concentration will be very, very high in IgA nephropathy. And now this will be able to activate complements locally, and that will result in C3 deposition. So which means in the biopsy, you might be able to see C3 deposition, but as far as the overall complement levels in the blood is concerned, you will not have complement decline in IgA nephropathy. That is one reason why you have a normal complement in the setting of IgA nephropathy. So which is very important to understand as well. So I told you the pathophysiology of IgA nephropathy, and let us come to the epidemiology of IgA nephropathy. Remember, IgA nephropathy is quite common in adults. If they ask you the most common type of nephritic disorder, the most common glomerular disorder in adults, most common nephritic syndrome in adults, whatever may be the case, it is IgA nephropathy. That's simple. A most common glomerular cause of isolated hematuria. So if they ask you anyway, most common glomerular cause of isolated hematuria, most common glomerular cause of hematuria in adults. Then what is the third? Most common glomerular nephritis in adults, most common nephritic syndrome in adults. So whatever may be the question, so it is always IgA nephropathy only. So this is the glomerular cause of hematuria, isolated hematuria, which is of glomerular origin in adults. And this is the most common nephritic syndrome in adults, most common glomerular nephritis in adults, most common glomerular disease in adults. So whatever may be the case. So that is IgA nephropathy only. That's why this is very, very important. But remember, I'm not telling most common cause of hematuria itself is IgA nephropathy. We have multiple other conditions like stones, UTI and all, which will be far more common cause of hematuria in adults. But glomerular reason, it's always IgA nephropathy in adults. That's why it's very, very important. But it's not like IgA nephropathy is going to happen only in adults. It can happen in children also. Which is what is very important for me. It can happen in children as well. Even though it's common in adults, but it can happen in children also. Children typically react in two ways. For example, if we take the clinical features, remember there is no specific clinical feature as far as IgA nephropathy is concerned. There is no particular clinical feature as far as IgA nephropathy is concerned. They don't have a clinical feature on its own. It's going to be the nephritic or nephrotic presence. That's why they're going to come. So one way they can present with this episodic gross hematuria. Episodic gross hematuria. That is one way where they can present. Frequently, they will get bouts of hematuria, or they can present like an asymptomatic microscopic hematuria. plus or minus proteinuria. Plus or minus proteinuria. These are the two ways of presentation how they can present. As far as episodic gross hematuria is concerned, which is very common in children very commonly compared to adults. So that's how they present in children. In adults, typically they come with an asymptomatic microscopic hematuria. Adults more than children. Adults more than children. Clear? So usually in children, you will have history of URI, but adults it is rare. You don't really get history of URI that commonly in adults. And at the same time, hypertension and acute kidney injury are quite rare in children, but common in adults. Slowly, I mean, they'll be little subacute, but still they do develop hypertension AK over a period of time. So children will go for remission very easily. Remission is extremely common, whereas in adults, remission is uncommon. You don't really get remission very commonly. It's very uncommon adults. So these are the two different ways of presentation of IgA nephropathy as far as children and adults are concerned. But even though there is substantial overlap between these two, it should not be taken very strictly. Adults also can present with episodic hematuria. Children also can come with microscopic hematuria, but even though rare. But nevertheless, these are two classic presentations with substantial overlap between them. That is what something you need to know. Then apart from that, in children, I told you they're going to present with hematuria, which is very, very important. So they do present with gross hematuria. There is one other condition in children that presents with gross hematuria. Can anyone tell what is another condition which is very common in children that presents with gross macroscopic hematuria or even episodic hematuria? I mean, these kind of very silly questions I'm asking just because I wanted to know whether you are awake or not. No, what is another condition? PSGN. PSGN is another condition that is going to come with gross hematuria and sometimes even episodic gross hematuria. So that is why to differentiate PSGN plus with IgA nephropathy is very important, especially in children. Suppose the same child is coming with a history of URI. Let us assume a child with history of URI, or maybe I can write pharyngitis here, and they are developing glomerulonephritis. Glomerulonephritis in the setting, like I'm talking about a gross hematuria here. So that's where you call it as a cola-colored urine, isn't it? That's what the characteristic description that is given in many pathology textbooks: cola-colored urine, or a tea-colored urine, or whatever it is, or a coffee-colored urine, whatever. So that's how they come, gross hematuria. You need to know the incubation period, which is very, very important. As far as IgA nephropathy is concerned, usually we'll have a short incubation period, extremely short incubation period, like if I have within a week, which means from the time of pharyngitis to glomerulonephritis is happening within a week, very short, 3 days, 2 days. That's why it's also referred to as something called a synpharyngitic. Synpharyngitic glomerulonephritis. If this is the case, then usually this will be an IgA nephropathy. Usually it's an IgA nephropathy. It's not PSGN. In case of PSGN, it will have a little bit of long incubation period as far as PSGN is concerned. Typically, they will be having an incubation period of approximately more than 1 week. Usually it takes 1 week to 3 weeks very commonly, but it will be a little more. It will be more than a week. So this condition will be a PSGN usually. In exam, this incubation period in children is a very big clue. Incubation period in children. Clear? More than a week from onset of pharyngitis to glomerulonephritis, it is usually PSGN. Within a week, if you develop, it is usually a IgA nephropathy, which is actually quite important to know. Okay. So these are the two classic presentations I told you, but they can have a variety of other presentations which can come with nephrotic syndrome. Very rare. IgA nephropathy coming with isolated proteinuria and a pure nephrotic syndrome, rare. We don't get, but still I have seen 2-3 cases of IgA nephropathy in adults coming with pure nephrotic presentation, which is also common. I mean, not common, but which is also seen. And second is they can come with a CKD, slowly progressing chronic glomerulonephritis kind of picture also. They can come with RPGN also. Clear? It's very simple. So which means they can come with a typical nephritic presentation. This is the commonest presentation. Commonest presentation is nephritic presentation only. That's how they're going to come. Or they can have a nephrotic presentation, or they can have an RPGN presentation, or they can come with the isolated hematuria or a proteinuria, or they can present with a chronic glomerular nephritis, like what I told you. So all the 5 presentations are possible in IgA nephropathy, even though the nephritic presentation is going to be the commonest mode of presentation of IgA nephropathy. So fine, we need to know. So of course, the gold standard for diagnosis is going to be the biopsy only, without a doubt. If you don't do a biopsy, you're not going to diagnose this disorder. But you need to know what is the light microscopic finding. We need to know what is the electron microscopic finding. We also need to know what is the immunofluorescence finding. All these 3 things are very, very important in biopsy. So remember, whenever you get a biopsy done, I mean, whenever you want to make a diagnosis of some glomerular disorder, the clinical presentation, light microscopy, immunofluorescence. These are 3 most important. Electron microscopy is not done routinely for all the disorders unless and until you strongly suspect some like glomerular disorder with organized deposits, where electron microscopy becomes very important. But apart from that particular entity, I don't really think that electron microscopy plays a very important role, except for the case of exams. It's not at all important in real time, electron microscopy. And I don't think really, apart from certain few pathology questions in exams, electron microscopy is going to be playing a very vital role for your mark scoring in exams as well. But nevertheless, let us see some few points that you need to know. As far as light microscopy is concerned, typically you will see mesangial proliferation. That is due to, because these IgA deposits are basically neutral deposits. I'll come back to that. Mesangial hypercellularity. These IgA deposits are basically neutral deposits. Because they are neutral deposits, they actually get deposited in the mesangium. So they trigger the mesangial proliferation because of local complement activation and inflammation that results in mesangial hypercellularity, which is the most common histological finding in IgA nephropathy. But please understand that mesangial hypercellularity is not a specific finding for IgA nephropathy. It can be seen in any other disorder that has deposits in the mesangium. SLE can cause deposits in the mesangium. Many other conditions can produce immune complexes that are neutral in nature, which can deposit in the mesangium, that can produce mesangial hypercellularity. Whether it's the most common and the characteristic finding of IgA nephropathy, it is not very specific for IgA nephropathy. You need to understand. In electron microscopy, what you're going to see these deposits in the mesangial electron dense deposits. This is what you will do. So whenever you see a mesangial electron dense deposits, very, very, very non-specific. I mean, maybe in exam it can go towards IgA nephropathy, but it is non-specific. Immunofluorescence, you will see a mesangial IgA deposits. Mesangial IgA deposits. Please understand that only in immunofluorescence you can tell whether the antibody is IgA or not in electron microscopy. Electron microscopy cannot tell it's IgA or not. It can tell only the deposits there or not. But immunofluorescence is where you see the IgA deposits basically. And you will see the deposit in the mesangium, which is very characteristic of IgA nephropathy. So these are 3 findings that you need to know. And treatment. I mean, before treatment, I can tell you the prognosis. The prognosis of IgA nephropathy depends on something called as a MEST-C scoring. And this is something that can be asked in exam. MEST-C scoring, it's an Oxford university-based scoring. That they are the ones who gave it. This M in this stands for mesangial hypercellularity. And this is a huge scoring, not important for our exam. Nobody's going to ask even for a super specialty exam. M stands for mesangial hypercellularity. E stands for endocapillary proliferation. E stands for endocapillary proliferation. ES stands for segmental glomerulosclerosis. GS stands for glomerulosclerosis here. And T stands for tubular atrophy. And C stands for crescents. Either it could be a cellular crescent or it could be a fibrocellular crescent. If it's a pure cellular crescent, it tells you it's more acute in nature. If it's a fibrocellular crescent, it tells you it's more subacute to chronic in nature. So presence of crescents just tell you it's a severe disease. It's in the rapidly progressing range. It's more towards very acute in nature, means it's very fast development, means it will be more of cellular crescents. If it's more of fibrocellular crescents with a little sclerosis is seen, means that will be more of a subacute to progressing towards CKD. That's what it means. It will be either a cellular or a fibrocellular crescent. So this is what we call MEST-C scoring. And depending on the specific points in that MEST-C scoring, we can tell whether it is a good prognosis or a bad prognosis, and we can assess the severity also. As far as the treatment is concerned, treatment is very simple. It depends on KFT or kidney function tests. So if the kidney function tests are completely normal, I'm not going to do anything. Just conservative management is more than enough. I'm not going to use any immunosuppression. Typically, like there is some evidence of fish oils are there, like omega-3 fatty acids and all. Usually I use the brand name called Caridepa, which is my favorite brand. So we use this fish oils, eicosapentaenoic acid and docosahexaenoic acid, EPA and DHA, which has some benefit. Plus, you need to give a routine management. Like you can give ACE inhibitors to control proteinuria if it's too much. So that could be the case. Or BP, if there means you're going to give some drugs that control the BP. So nevertheless, suppose if KFT is abnormal. So what do you mean by a grossly abnormal KFT? If the patient is having elevated serum creatinine, or if the patient is having proteinuria more than 1 gram per day, you do use conservative management. Plus, at the same time, I'll be using immunosuppression. Typically, I start with steroids. Steroids itself is enough most of the times for IgA nephropathy. But if this is the case, then I'll be starting with immunosuppression. But please understand, the MESC scoring also can strongly tell whether to use immunosuppressions or not. Suppose if I'm going to have severe endocapillary proliferation, crescent formation and all, apart from mesangial hypercellularity, still I can go ahead with starting with steroids. Or if I see significant crescents, then I can even start with high-dose immunosuppression like cyclophosphamide also. But grossly, as per the clinical understanding, this is going to be the reason for starting immunosuppression. But whenever I talk about this immunosuppression depends on a lot of other factors, like what is the amount of endocapillary proliferation, what is the amount of crescent needed to, what is the level of immunosuppression needed to control this crescent formation and endocapillary proliferation. This is the treatment of IgA nephropathy. So it's very simple, straightforward, elegant. IgA nephropathy is very important for exams, how they present, what is the pathophysiology, what is the basics, what are the biopsy, electron microscopy, and light immunofluorescence findings, and what is the prognosis. All these things are extremely important. So it all depends on how you understand these disorders and how you move from that point onwards. So this is what is going to be the importance of IgA nephropathy. Let us move on to the next disease, that is PSGN. But before that, let me ask you the same question, whether you understood this IgA nephropathy or not, how to treat and how to understand, how to identify this. Clear. After finishing this IgA nephropathy, let us move on to the PSGN, that is post-streptococcal glomerulonephritis. This is also called as infection-related glomerulonephritis, but let me tell PSGN as a very important entity, post-streptococcal glomerulonephritis. So typically it happens due to the group A beta hemolytic streptococcus. We call it as GABHS, group A beta hemolytic streptococcus. It is nothing but Streptococcus pyogenes. That's why we're calling it as a group A beta hemolytic streptococcus. Remember, this group A beta hemolytic streptococcus can result in development of pharyngitis as well as skin lesions. They can produce pharyngitis as well as they can produce skin lesions. Typically, for example, they can produce impetigo. Clear? They can produce pharyngitis or they can produce impetigo also. But remember, you can get glomerulonephritis, that is PSGN, after pharyngitis as well as after impetigo, but only the incubation period will be a little different. Usually it will be 1 to 3 weeks as far as pharyngitis is concerned, and 1 to 3 months as far as impetigo is concerned. Impetigo is having a little bit more incubation period compared to that of pharyngitis. But remember, only pharyngitis generally tends to produce rheumatic fever. Impetigo, skin lesions, usually does not cause rheumatic fever. That's very important to know. So same GABHS, Streptococcus pyogenes, pharyngitis strains can produce impetigo. Pharyngitis strains can also produce rheumatic fever, but impetigo strains does not produce rheumatic fever, whereas both pharyngitis as well as impetigo strains can produce glomerulonephritis. So there are some nephritogenic strains for that matters. So there are 2 more things that you need to know. So in Streptococcus pyogenes or in group A beta hemolytic streptococcus, there is some nephritogenic strains as such, so which you need to know. So it depends on a particular M type. At the same time, there is something called Griffith type. In that usual common question exam is that Griffith types is what they will ask. The Griffith types 12, 4, 1. So, or I can tell 1, 4, 12. So neither way, but 12 is very common. So this is usually the one that produces the glomerulonephritis. These 3 Griffith types, which are very important, and multiple other M types are there that can produce PSGN as well as other problems. Okay. Then what are the antigens? We know these are nephrodogenic strains, but there should be some antigens that serve as an antibody, causing a molecular mimicry, causing immune antibody formation and immune complex formation, subsequent immune complex deposition in the kidney, producing PSGN. The antigens that is associated with this development of PSGN is something called as NAP1R or NAP1R. So it is called a nephritis associated streptococcal plasmin receptor 1. NAPR1, or I can write NAP1R. This is nephritis associated streptococcal plasmin receptor 1. That's called a NAP1R. Or it could be like streptococcal pyrogenic exotoxin B. That is called SPEB. That's called streptococcal pyrogenic exotoxin B. And we can have something called a zymogen precursor. Zymogen precursor. So these are three things that can happen. Clear? These are three things that are important. So NAP1R, SPEB, that is streptococcal pyrogenic exotoxin B, and zymogen precursor. In that, SPEB is the one that's very important. Clear? Streptococcal pyrogenic exotoxin. That's what the common question in exam as well. So what is the problem? So these antigens are basically going to activate the complement, because we know there are two types of complement are there. When you take the complement, they're going to produce, we have something called a classic complement pathway and even an alternate complement pathway. To write complement in a nutshell, this classic complements are going to start from C1q, then they progress towards C2. Maybe you can write C4 first, then C4, they're going to activate C4, which activates C2, which activates C3 subsequently. Whereas alternate complement pathway straight away activates C3, but more importantly, we can write factor B and properdin here that are very important. So this activates C3 directly, and from C3 you form the terminal attack complex C5 to C9. So this is the nutshell of what is happening in the complement pathway. But we need to know that what is going to activate the classic complement pathway. To activate the classic complement pathway, we need to have the antigen antibody complexes. So that is the basic thing that activates the complement pathway, classic complement pathway. The best example is SLE. SLE, it's a storehouse of antigen antibody complexes everywhere in the body. So they're going to activate the C1q, which is going to activate the classic complement pathway. And whereas the alternative pathway is concerned, it's typically activated by microbial components in reality. So many microbial components, bacterial components can activate factor B and properdin, which can further activate the C3. So whenever diseases like SLE is there, because of the activation of the classic complement pathway, you're going to have reduced C1q, you're going to have reduced C4, you're going to have reduced C2, as well as you're going to have reduced C3, which means in reality, we measure only C3 and C4, both of which will be reduced as far as SLE is concerned. But if you take a disease which activates only the alternate complement pathway, like for example, a PSGN, here PSGN is due to microbial components which can directly activate the complements of the alternative pathway. Because there is only alternative pathway complement, so you'll be having reduced C3 alone, but you'll have normal complements. Other complements will be typically normal. So this is what is going to happen in PSGN. So PSGN is more of a complement-mediated damage. Complement-mediated damage that is happening due to immune complexes. Most often a complement-mediated damage due to development of immune complex, and more often there's a circulating immune complex. So that is going to get deposited in the kidneys and produce a lot of problems. And these immune complex in PSGN are mostly cationic in nature. That is why they typically get deposited in the subepithelial regions. That is the reason. And most of the complex, it's not like they will have only cationic complex. They can have anionic complex as well, but it's mostly cationic complex. That's why they tend to get deposited in the subepithelial regions predominantly. And it's predominantly a complement damage due to development of immune complexes. So that is why there are some threes that are very important as far as this PSGN is concerned. Usually you can think about a 3 weeks incubation period, 3 antigens that are very important, and it's a type 3 hypersensitivity reaction. Type 3 hypersensitivity reaction. So there are many 3s are there. So 3 weeks incubation period, 3 antigens are important for production of PSGN, and 3 hypersensitivity reactions are there that can produce. A type 3 hypersensitivity is the one that produces this kind of PSGN, post-streptococcal glomerulonephritis, which is really, really important. And what are the clinical features as such? How they are going to present really? ஹலோ மோசஸ், நான் கிளாஸ்ல இருக்கேன் மோசஸ். அப்புறமா கால் பண்ணிட்டு நான் பண்ணிட்டேமா, திருப்பி அடிச்சிட்டே இருக்கேன். நீ அதுக்கு தான் எடுத்தேன். நான் முடிச்சு பிரேக்ல பண்றேன். Okay. So this low C3 is very, very important as far as the PSGN is concerned. So whenever you talk about PSGN, in exam, they'll always ask about that low C3, which is very classic and very important as far as PSGN is concerned. So this glomerulonephritis, if you take the histology, for example, let us start with the light microscopy, then as usual, electron microscopy, because we need to know the diagnosis, biopsy. Light microscopy, electron microscopy, and probably you can think about immunofluorescence. What are the features that you will see? Even though these are classic findings in PSGN, but this is not specific for PSGN. Many other diseases also can produce a similar finding. So let me come back to that. So light microscopy, typically you will be see a glomerular hypercellularity. Everyone knows what do you mean by glomerular hypercellularity. Whenever you see a glomerular hypercellularity, it is suggestive of an APGN. That is acute post-streptococcal glomerulonephritis. That is APGN. Not post-streptococcal, acute proliferative glomerulonephritis. So APGN is a separate type. So whenever you have glomerular hypercellularity, you can tell it is just an APGN, acute proliferative glomerulonephritis. That's all. So all the cellular components will be proliferated. Your parietal epithelial cell, vessel epithelial cell, your capillaries and mesangial cells, everything will be proliferated here. It's just APGN means it's glomerular hypercellularity. By definition, glomerular hypercellularity means you should have more than 100 nucleus in a particular glomerulus. So this is what we call the glomerular hypercellularity, and that's what you see in PSGN. PSGN is basically a type of APGN, acute problem. So which means that's all. So that's non-specific. So any other APGN due to any other immune complex deposition can produce glomerular hypercellularity. So that's not a specific finding. So come to electron microscopy. Electron microscopy, typically you will see something called as a subepithelial humps. This is the word that you will get in exams usually. The subepithelial humps are also referred to as something called as lumpy bumpy deposits. And again, presence of this lumpy bumpy deposits tells it's just APGN. That is acute proliferative glomerulonephritis, which means any other condition that produces acute proliferative glomerulonephritis can have this lumpy bumpy deposit, subepithelial humps. So again, it's not specific for PSGN. When you come to immunofluorescence, once again, this is not specific for PSGN, but in exam, there are certain words that will point towards PSGN. So like, for example, you see something called a garland appearance or probably a starry sky kind of a pattern. So this is what they will give. But again, this suggests it's just an APGN. In any other condition that produce acute proliferative glomerulonephritis, you can get this garland appearance or a starry sky pattern of distribution. So nothing is actually specific for diagnosing PSGN. So all these findings, if in reality, if you ask, is equal to PSGN or not, it's not equal to PSGN, but it's equal to APGN. These are very characteristic findings of APGN, but it's not equal to PSGN. That's all. That is the most important point to note here. So then how will you really diagnose whether it's a PSGN or not? So that is why if you have this finding, plus that is why your textbooks will emphasize on one important point, that is history of antecedent streptococcal infection. Or not history really, that evidence of antecedent streptococcal infection. More than history, you should have this evidence of antecedent streptococcal infection. So now you can call it as PSGN, post-streptococcal glomerulonephritis, which means APGN, acute proliferative glomerulonephritis, with evidence of antecedent streptococcal infection, you can call it as a PSGN. Otherwise, you cannot really call it as a PSGN in the first place. So what are the things that tells you that there is an evidence of a antecedent streptococcal infection? So number one, we use some enzyme panel. Listen, that's called a streptozyme panel. Streptozyme panel, that is what we are going to use basically. So when you talk about the streptozyme panel, there are three antibodies are there in this. One is called as anti-streptolysis in vivo titers. So that's called ASO titer. And the second one, we have something called as anti-DNase B titers, DNase B titers. And third one, we have something called anti-hyaluronidase titers. Anti-hyaluronidase titers. Remember, once again, there is It's nothing like ASO titer is specific, anti-DNSB titers are specific. Again, it's the misinterpretation of what is given in the textbooks is the usual thing that creates a confusion. Nothing is specific or nothing is sensitive. I mean, in reality, it's better to use all these three things. Suppose if you're going to use all these three things, now the sensitivity becomes more than 90%. So in our hospital, we have a separate panel called as a streptozyme panel. That is what we use. Whenever you use all three panels, all three antibodies together, now the sensitivity will become almost more than 90%. But there's another one that's called anti-streptokinase antibodies also. But this is not present in our hospital, but Western countries use this anti-streptokinase. If you use anti-streptokinase, now the sensitivity becomes almost 93-95%. But when you use only three, the first three, the sensitivity becomes almost around just above somewhere around 90-93%. But if you use anti-streptokinase, the sensitivity will be even more higher. The more and more the number of antibodies include, the sensitivity will become more and more better. But please understand the sensitivity of ASO titers alone are different. Sensitivity of anti-DNS titers alone are a bit different. And again, it depends on what is the type of disease that you get. For example, in people who are having pharyngitis, and this pharyngitis most of the time will be epidemic in nature. Epidemic means it happens in school children and it will easily spread to other school children, other classroom children, or other school children. Suppose if it's epidemic in nature, and if there is a pharyngitis related glomerulonephritis, then in this setting, the sensitivity is very high, more than 70%. If you use only this streptolysin O, ASO titer, in this patient, the sensitivity of ASO titer is very high because in this setting, usually the ASO titer is the one that will be elevated predominantly. For anti-DNSB titers, for skin lesions and for non-epidemic cases, non-epidemic is sporadic cases. Non-epidemic is equal to sporadic cases. For sporadic cases and those patients who are typically having skin lesions, sensitivity of anti-DNSB titers are very high, which will be more than 70%. So again, what antibody will dominate in a particular patient depends on what is the disease and what is the underlying problem. And whether it's epidemic or non-epidemic or pharyngitis or skin, that is going to tell you which antibody will be present. So that is the reason to avoid all this confusion. If you don't know whether it is epidemic or non-epidemic or pharyngeal skin related, it's better always to go for this complete streptozyme panel, which is going to have a sensitivity of more than 90%. If we do not have evidence of antiserine streptococcal infection, it should not be called as PSGN. It will be just called as APGN due to unknown cause. That's all. As simple as that is in reality. That's how you have to really diagnose in condition. A second example of this antiserine streptococcal infection or present streptococcal infection will be throat culture. Throat culture. This throat culture is usually negative. It won't be usually positive. It can be positive, especially in epidemic cases. Epidemic cases means there will be clusters of cases. So you can identify the, culture positivity very easily. In throat cultures, the yield is low, but still in epidemic conditions, usually it will be positive. So this is the evidence of antiserine streptococcal infection. This is what the biopsy finding, and this is what you need to know. So in exam, whenever you see this kind of findings, you go for PSGN, but in reality, it doesn't go really towards PSGN unless until you have an history of antiserine streptococcal infection. And in worst cases, in light microscopy, you can have crescents also. So I told you, whenever you have crescents, it indicates a little subacute course. At the same time, it's more severe disease. It's actually in between that's causing a lot of confusion. So it can show a little bit of crescents, which is evidence of very, very high disease activity, which is very important as well. And similarly, prognosis wise, we don't have any separate scoring system for prognosis, but children, especially in children, we have these epidemic cases. Epidemics, you have an excellent prognosis, very, very good prognosis. Almost 100% will go for recovery. 100% will go for recovery. Less than 1%, they can progress towards RPG. Possible in children. But overall, everyone will recover. Most of them will recover. Less than 1% can go for RPG. It's usually a transient disease. But in adults, where you see a lot of sporadic cases. In children, you don't see sporadic cases. In adults, where you see a lot of sporadic cases, the prognosis is guarded prognosis, which means only 60% will show a good recovery and 40% may progress towards a chronic glomerulonephritis also. So which you should be aware of. They can progress towards CKD. Treatment wise, it's only supportive treatment. There is no definitive treatment. If there is any evidence of ongoing infection, you can give penicillin antibodies. Penicillin or erythromycin or clindamycin, some form of antibody may be helpful. So if the patient is having some ongoing evidence of infection, but most often routinely we add this antibiotics, but I mean, according to textbooks, only if there is evidence of infection, you can give antibiotics. But apart from that, the supportive treatment, which I've told you in the past, will be very good for this also. So this is PSGN. So this is how you diagnose a PSGN. And the complement levels, the most important here is low C3. Extremely important as far as PSGN is concerned. If you understand this, I can move to the next disorder, that is RPGN. Do you understand? Do you understand? Yes. Okay. So the next disorder, maybe we can call it as a sandwich disorder in between, is the crescentic glomerulonephritis. Crescentic glomerulonephritis. Because we are talking about glomerulonephritis, so we can also call it as an RPGN, but in reality, it won't be called as an RPGN. They will present like an RPRF only, where there will be doubling of serum creatinine within 6 weeks. That is the definition of RPRF. So they will present with RPRF only. Then if you evaluate that RPRF, if they have a nephritic presentation, then I'll be called as an RPGN. So this is how I make a diagnosis of RPGN. But apart from that, in clinical presentation, they will be coming like RPRF only. That is rapidly progressing renal failure only. So as far as crescentic glomerulonephritis is concerned, we know there are 3 different types of crescentic glomerulonephritis, but the most important histological finding is light microscopic finding, where you see crescents. We are going to see crescents. Crescents are one of the most important histological features of crescentic glomerulonephritis. And this crescents typically made of parietal epithelial cell that are proliferated along with glued together with fibrin or thrombin. Fibrin and thrombin and glue this parietal epithelial cells together. So this is what is going to form a crescent. And the problem with this crescent is going to result in obliteration of the glomerulus. Obliteration of the glomerulus and the Bowman's capsule. The urinary space will be obliterated, and that is the reason for the renal failure. The main reason is this only. So you need to somehow form prevent the proliferation of this parietal epithelial cells and fibrin deposition. So to prevent the further crescent formation and to retard the already formed crescents by giving some cytotoxic drugs. That is the idea. So you have to destroy this parietal epithelial cells and immune cells. Along with it, you have to break the fibrin also. That is the reason why we give this anti-cancer drug, cyclophosphamide, which is very important in the treatment of crescents. So nevertheless, so whenever you have this crescents, so the next step, if they ask you, are going to do only immunofluorescence, which I told you already. In the immunofluorescence, if you see positivity or negativity, that is very important. As far as positive immunofluorescence is concerned, now you see the pattern of immunofluorescence. As far as pattern of immunofluorescence is concerned, it could be either a granular, coarse granular deposits, or a linear and smooth deposits. Linear smooth deposits. If you see a granular coarse deposit, it just tells you it's an immune complex related RPGN. That is just a type 2 RPGN. That is granular and coarse, immune complex related. For example, it could be due to SLE, it could be due to IgA nephropathy, it could be due to PSGN itself, or any other cause of APGN. It could be due to enoxaparin purpura, it could be anything. So we need to evaluate further. So to find out what is the underlying cause, we need to evaluate further. For example, in SLE, you have anti-dsDNA. In IgA nephropathy, you will be having normal C3, whereas in SLE, you will have low C3 and C4. PSGN, you will be having low C3 alone. History of antisense streptococcal infection will be there. So further evaluation is very, very important. Further evaluation is important to tell what is the underlying cause. Clear? So this is what we're going to do here. As far as smooth and linear deposits is concerned, typically we are dealing with an anti-GBM, antibody kidney disease. It could be Goodpasture syndrome. It could be Goodpasture if lung is also affected. If lung is also involved, you call it as a Goodpasture syndrome. Otherwise, it will be just called as an anti-GBM antibody kidney disease. The next step here, you can evaluate anti-GBM antibody testing. Anti-GBM antibody testing is commercially available. You can do the next test in this. So if immunofluorescence is not available, I mean in the sense like immunofluorescence is negative, which means you don't see any immunofluorescence, then this will be called as a post-immune variety. This anti-GBM antibody is what we refer to as a type 2 RPGN. We know that post-immune variety is what we refer to as a type 1 RPGN. Type 3 RPGN, we know that. Sorry, anti-GBM is type 1, post-immune is type 3. Post-immune is type 3 and anti-GBM antibody is type 1. As far as post-immune variety is concerned, usually it will be ANCA-associated vasculitis, very commonly. They'll be having some ANCA. You have to look for the ANCA. So next step is to see what is ANCA. What is ANCA, and also see the clinical features. So if you are seeing a C ANCA, patient is having ENT manifestation, plus or minus ENT manifestation, usually the answer will be Vaginous granulomatosis. C ANCA, we know it is anti-PR3 antibody, proteinase 3 antibody. The next, if you see a P ANCA, and you see what is the clinical manifestation in the P ANCA. P ANCA, if you see predominantly a pulmonary renal syndrome kind of a picture, PRS means pulmonary renal syndrome kind of picture, go for microscopic polyangiitis. And suppose if you see more of asthma kind of a presentation, asthma, GIT involvement, cardiac involvement, neurological involvement, so then usually it goes towards a Chooks-Strauss syndrome. And the patient, I mean, more than writing all these things, I can write in exam asthma and eosinophilia. Patient is having asthma and eosinophilia. So think about a Chooks-Strauss syndrome. Suppose if there is patient is having no systemic vasculitis, then it goes towards a renal limited vasculitis, which means it's only the kidney that's affected. Usually it's idiopathic. Renal limited vasculitis, no systemic vasculitis, no other organ involved, only kidney is damaged, P ANCA positive, post-immune variety, think about a renal limited vasculitis. So this is how you go about crescent formation light microscopy. Usually these are the causes that generally produces RPRF as well. These are conditions that produces clinically rapidly progressing renal failure. At the same time, they will produce RPGN as well. And electron microscopy is not important here. Electron microscopy depends on what is the underlying problem. For example, immune complex deposit depends on what is the underlying problem, so that you will get that particular electron microscopy finding. At the same time, similarly in anti-GBM antibody, you will see that deposits along the GBM in electron microscopy. There will be electron dense deposits. These are antigen antibody complexes, deposits along the base membrane, and that's what you will see in electron microscopy. Once again, in ANCA-associated vasculitis, you don't really need electron microscopy, or nobody will really give electron microscopy, because it's totally a diagnosis of your clinical expertise and ANCA-based diagnosis, so it's not really needed here. And if you ask about the complements level typically will be normal in ANCA-associated vasculitis, because they don't even activate the immune complexes, which means post-immune variety means there is no immune complexes here. They don't even activate the immune complexes. So it's unlikely that the complements will be consumed. So it's normal complements. As far as this linear things are concerned, once again, the complements will be normal here. There won't be any much change in the complements, because I told you already in the pathophysiology, the activation of complements and the decline in the complements in the blood depends on what is the antigen and many other factors. Here the antigen is in situ, intrinsic antigen. Because it's an intrinsic antigen, it's not a generalized antigen that is present in the blood or elsewhere. It's an intrinsic antigen, only local complement activation may be there. So I don't really think that local complement activation is going to consume a lot of complements, resulting in a dramatic decrease in the complements. So it generally doesn't happen. As far as the immune complex is concerned, immune complex related glomerular lymphadenopathy is concerned, the complement levels will be variable. Depends on what is the underlying disease. Most often it will be reduced only because the diseases are PSG and SLE and all. But if it's IgA nephropathy, the complement levels may be normal also. It's variable. So it depends on what is the underlying disease. But among the treatment options are concerned, whenever you see crescents, RPGN is equal to high level immunosuppression. You have to give a high level immunosuppression, no doubt about that. Typically, you will start with a IV pulse methylprednisolone, which I told you 1 gram for 3 days. That's what we give. Along with that, we add a cyclophosphamide, or alternatively even rituximab is considered to be very helpful. But in reality, very commonly we add cyclophosphamide. But in resource-rich settings where there is a lot of expertise, you can start with rituximab also, no problem. Third, we might add a plasma exchange if you want. So these are the 3 standard therapies. As I already told you, there are only few indications of plasma exchange in vasculitis. One is the RPGN, that is crescent. Second is the diffuse alveolar hemorrhage. And third, you can think about a TTP, thrombotic thrombocytopenic purpura, due to SLE. So these are the typical indications where you can use plasma exchange. Otherwise, we don't really use plasma exchange. The treatment becomes IV pulse methylprednisolone with cyclophosphamide. So these are the treatment options that are available for crescentic glomerulonephritis. As far as crescent is concerned, the word crescent means you need to give a high level immunosuppression. Do you understand this crescentic glomerulonephritis, so that we can move on to the next step? Do you understand? Don't you? Clear? Okay. Let us move on to some few other glomerular disorders, which are going to have a nephritic and a kind of a presentation. What is the other disorder? For example, one more important disorder is SLE. SLE is a very important disorder. I think we have discussed very decently about this SLE in reality, so I don't think we really need to worry much about this SLE. They're going to cause lupus nephritis typically. And my question is, what classes of lupus nephritis comes with nephritic presentation or glomerulonephritis? Because you're talking about nephritic presentation. So what kind of lupus nephritis typically comes with nephritic presentation? What did you say? What's your take? Hello? I think we discussed in detail about lupus nephritis, didn't we? I think we. I'm sure. I've discussed. Yes, type 3 and type 4. Not type 3, class 3 and class 4. Class 3 and 4. Class 3, 4 lupus nephritis is the one that typically presents with nephritic presentation. But remember, they can be associated with crescents, because type 3 and type 4 usually they will present like APGN. Usually they will present like APGN, acute proliferative glomerulonephritis, or otherwise referred to something called a DPGN. That's called a diffuse proliferative glomerulonephritis. I mean, type 4 is the one that's called as a DPGN, but histological variety will be usually APGN, that is acute proliferative glomerulonephritis, which can, if severe, sometimes they can have crescent formation also. If there is too much crescent formation, many of the glomerulus are showing crescents, then you have to start with high level immunosuppression. But nevertheless, 3 and 4 also on classic examples of APGN. So APGN, that's why in class 3 it will be either focal, less than 50% of glomeruli are involved, or it can be diffuse, that is more than 50% of the glomeruli will be involved. It could be either focal APGN or a diffuse APGN. So based on that only we are going to give class 3 or class 4, but uniformly they are dangerous because they are acute, and they can have crescents, which is suggestive of RPGN also. They can either come with an APGN, which is very classic, or they can go towards RPGN also. Nevertheless, both needs high level immunosuppression, because in lupus, immunosuppression is a very important entity, and organ involvement in lupus especially has a even more higher reason why you should give a severe immunosuppression. And we are going to give a very severe immunosuppression. SLE. Remember, SLE is a secondary disease. Till now, we talked about primary disorders. SLE is basically a secondary glomerulonephritis. And many other things can cause, like maybe I can talk about an MPGN. I can finish off here. Even MPGN most often comes like a nephritic kind of a presentation only. But in some textbooks, it's given as a mixed nephritic and nephrotic. But I believe MPGN is more of a nephritic kind of a presentation only. And sometimes it can be a mixed nephritic as well. And why it is called MPGN? MPGN is otherwise called as AKA MCGN. It's also called as MCGN. That's called a mesangiocapillary glomerulonephritis. But why it's called as an MPGN? Again, it's based on light microscopy finding only. MPGN means membrano. Okay, we know that. What is membrano? Membrano stands for thickening of the base membrane. You will see thickening of the base membrane here. And at the same time, you will be seeing proliferative, membranoproliferative. So why proliferative? Because you will be seeing cellular proliferation. There will be increased amount of cells will be there. That's very classic. And why glomerulonephritis? Because they're going to typically have a nephritic presentation most often. That's why it's called as a membranoproliferative glomerulonephritis. That's the reason why we call by that name. And increased cells, what are the cells that typically increases in MPGN? That's why the other name is there, mesangiocapillary glomerulonephritis, which means typically two types of cells are going to increase in MPGN, that is mesangium and endocapillary region. So these are the things that are going to proliferate. That's why it's called a mesangiocapillary glomerulonephritis as well, otherwise referred to as MPGN. And typically, usually, because it's a highly inflammatory state and so much of cells will be there, and they produce some classical light microscopic findings. I told you they are typically going to come with a nephritic sort of presentation only, but we need to know what they're going to produce in light microscopy, what they're going to produce in immunofluorescence, and what they're going to produce in electron microscopy. But light microscopy findings here are very, very important. Most of the case of MPGN, as such, they will be having thickened base membrane, and maybe I can write here itself that thickened base membrane is the one that results in formation of something called as base membrane proliferation or base membrane thickening, which will look like as if the base membrane is duplicated, or I can leave it off. I mean, it's better not to confuse. There will be thickening of base membrane. Along with it, these cells that are coming along with a lot of inflammation that is seen, there will be too much of inflammatory infiltrate will be there. That along with this thickening of base membrane typically produce an appearance of something called as a double contour. Double contour appearance. This is very classic. And I mean, not seen all the cases, but very classic. And that's what your exam questions will be. This base membrane, thickened base membrane with double contours. So double contour appearance is also otherwise referred to as something called a tram track appearance, or probably a trolley track appearance. Or probably you can even think about something called as a split appearance, base membrane split. So any of the terms can be asked: tram track, trolley track, split appearance. So it could be the case. So this is what is the characteristic feature of MPGN in light microscopy and electron microscopy as far as exam is concerned. Not seen all the types, but very classic of MPGN, membrane proliferative glomerulonephritis, where few cases of MPGN will have a base membrane, like I told you. In between, there will be a split appearance. Split appearance. Why they're going to have a split appearance like this is because of the infiltration of the base membrane with some inflammatory infiltrate. And some cells will infiltrate the base membrane, thereby producing a split in between the base membrane at certain areas in the glomerulus. That's called a split base membrane, or a trolley track appearance, or a tram track appearance, or a very common name in pathology textbooks is base membrane with double contours. So that is very classic. And as far as MPGN is concerned, there are many different types of MPGN based on our clinical, histological, electron microscopic, and immunofluorescence finding. The first type is what we refer to as a type 1 MPGN, or typically I can write as something called as a immune complex related MPGN. I believe that this is the right name. This is a new name also, immune complex related MPGN. And second type, we have something called a type 2 MPGN. Type 2 MPGN, which is otherwise referred to as complement mediated MPGN, complement MPGN. And we have another type called as a type 3 MPGN, which is also basically a complement mediated MPGN. Apart from that, we have an extra type, which I'll tell you after some time. So basically type 1, type 2, and type 3. Type 1 is immune complex related. Type 2 is, and type 2 and type 3 are only complement mediated. They won't have any immune complexes here. As far as type 1 is concerned, if you take the deposits, what you will see, typically you will be having immunoglobulin deposits plus C3 deposit. This immunoglobulin can be IgG very commonly. And along with that, you can see IgM also, but IgG is very common as far as kidney is concerned. Ig and IgM deposits along with C3 will be there. On the other hand, type 3 and type 2 will have only C3 deposit. They won't have any other immunoglobulins at all. It's C3 only. C3 only. And that is the reason why this type 2 and type 3 in certain textbooks are also referred to something called as a C3 glomerulonephritis. Type 2 and type 3 are also referred to something called as a C3 glomerulonephritis or C3 related glomerulonephritis. That's how they call it. But I mean, in reality, don't use these kind of terms. They'll have only C3, and that is the reason why they're called as C3 glomerulonephritis. They don't have any immunoglobulin deposits at all in the first place. So let us see the etiology. As far as etiology is concerned, this could be either a primary or a secondary disorder. Many of the glomerular disorders will be primary, but this is one type which is predominantly secondary, which means usually primary means idiopathic, which is very, very rare. Getting idiopathic type 1 MPGN. Whenever you see a type 1 MPGN, it's almost always due to probably some sort of infection, very commonly. The infections that are very commonly associated with type 1 MPGN is HCV. They can be seen with infective endocarditis. Or there is another entity called a shunt nephritis. That is due to infection of the ventriculoperitoneal shunt. That is done for a lot of disorders. So shunt nephritis, or it can be due to HBV, rarely, but HBV, even though produces MGN, membranous glomerulonephritis very commonly, but it can produce MPGN also. Or you can get with brucella, you can get with Q fever, and you can get with meningococcal infection. And it can be seen in malaria. Remember, malaria causing glomerulonephritis is very rare. Only one species can produce glomerulonephritis in malaria, that is Plasmodium malaria species. Plasmodium malaria can produce membranous glomerulonephritis or membranoproliferative glomerulonephritis, but very commonly they produce MPGN type 1 only. Malaria is very, very important. Only one species is able to produce glomerular disease, that is Plasmodium malaria. Remember, falciparum causing black water fever is due to hemoglobinuria. That's AKE. That's due to hemoglobin deposition. Here we are getting glomerular disorder. That is with Plasmodium malaria. Or you can get with certain conduit tissue disorder, conduit tissue and rheumatological disorders. Infections first. That's the usual cause. CTD and rheumatological disorders. Very important is cryoglobulinemia. Cryo is an extremely important entity. And apart from that, you can get in SLE, very rarely in rheumatoid arthritis or Sjogren syndrome, but it's usually cryo. MPGN type 1 means only two things. That is cryo HCV. As I already told you multiple times, only two things. Cryo and HCV. These are only two things that you need to know for exams. Then it can be seen in various paraproteinemias also. Like multiple myeloma, MGUS, Waldenstrom's macroglobulinemia. You can get. As far as complement-mediated MPGN is concerned, usually these have a shared common pathophysiology where you will have a defect in the alternative complement pathway. Alternate complement pathway defect. Remember, if you go back to the complements and see, I don't want to waste much time on it, but still there is one thing called a C3 C3 convertase will be there. So they will form something called as an alternate pathway C3 convertase. I don't want to waste time on what is this C3 convertase. There is something called alternate pathway C3 convertase. And we also have, at this point, we also develop something called a classic pathway C3 convertase. Both are different, but nevertheless, these are very important enzymes that are important for the formation of C3 or activation of C3. So this alternate pathway C3 convertase is usually inhibited by a variety of factors, but it can be unduly stabilized by certain factors. Like for example, one important factor is something called a C3 nephritic factor. That's called C3NF, which can be unduly stabilized. So actually C3 nephritic factor is an antibody basically that is produced in certain situations. This is an aberrant antibody. This is not a good antibody. This antibody, instead of destroying, usually antibody means destruction, but here it don't destroy, it actually stabilizes the alternate pathway C3 convertase. Because of over stabilization of alternate pathway C3 convertase, you are going to result in more activation of alternate complement pathway. And that is the reason for complement activation. And that is the reason for glomerular damage that is proposed in these patients with this kind of complement-mediated glomerulonephritis. At the same time, this factor B and factor B and properdin, as they activate the ALT pathway, there is other factors that inhibit this ALT pathway complements, that is factor H and factor I. So sometimes you can have this loss of function mutations of factor H and factor I that can result in overactivation of ALT complement pathway, because they basically inhibit the ALT complement pathway, or there can be a gain of function mutation of factor B and properdin. So because if there is a gain of function mutation of factor B and properdin, you can result in overactivation of ALT complement pathway, results in too much of C3 production, C3 deposition in the kidneys, resulting in C3 mediated damage on the kidney. So that's why in these conditions, usually only C3 will be low. Other things may not be low. That is very important to know. So whenever they ask you this typical complement-mediated disorders, in exams, there are few things that you need to know. So one is the classic type 2 and type 3 MPGN, which you're talking about, otherwise referred to as a complement-mediated MPGN, or simply I can write as complement-mediated MPGN. And the second one that is very important in exams is the atypical HUS. Atypical HUS, otherwise referred to as a HUSD minus. HUSD minus, but simply we can call it as a complement-mediated HUS. And this is a right name. So remember, the term atypical HUS means it's very wrong. Why I'm telling it is very wrong, HUS D minus atypical HUS, because there are many other variety of HUS are there, which will be called as atypical HUS. So to be specific, if complement problem is the one that's causing hemolytic uremic syndrome, it's called a complement-mediated HUS. On the other hand, if the patient is having a MPGN, then it will be a complement-mediated MPGN. So, but nevertheless, whatever may be the disease, the problems will be either C3 nephritic factor, or loss of function mutations of factor H or factor A, or gain of function mutations of factor B and properdin, which is actually producing too much of C3, consuming too much of C3 in the blood, thereby resulting in fall in C3 levels, actually causing damage to the particular area, either the vessel of all the areas in the body, or selected vessels in the body like glomerular vessels, which can cause glomerulonephritis. This is what is happening here. So this problem in the alternate complement pathway can be either, as I told you, it could be a C3 nephritic factor, or loss of function mutations of factor H and factor I, or probably gain of function mutations of factor B and properdin. So these are the reasons why you can get a problem in this situation. And usually, if you take the complement-mediated MPGN, so one important thing that differentiates this type 2 and type 3 MPGN is only the electron microscopy. If you don't have electron microscopy or don't have immunofluorescence, you cannot differentiate this complement-mediated MPGN. Both of them will have low C3. For example, let us see what will be the other things that you can note here. So if you take the immunofluorescence, maybe first let us talk about the immunofluorescence to start with. If you take the immunofluorescence, you will have immunoglobulins and C3 deposition here, as I told you. But here you are going to have only C3. C3 only you will be having without any immunoglobulin deposition. If it's only C3 means, in type 2, you will be having one additional finding that's very classically asked in exam, that's called the mesangial rings. This immune complex deposit will form rings within the mesangium. These are called as mesangial rings. But in type 3, typically you will not see any mesangial rings. When you move to the light microscopy, so what are the findings in light microscopy? Typically, you will be seeing the subendothelial deposits here, whereas here you will be seeing subepithelial deposits predominantly, but it's quite variable. In type 2, you will be seeing subepithelial deposits and deposits within the base membrane. Subepithelial and base membrane deposits. This is what you see in type 2. And in type 3, it is actually quite variable. You can see deposits anywhere, but this is not important at all. I'm writing about electron microscopy. Electron microscopy, typically you will be seeing subendothelial deposits. Here you will be seeing subepithelial and base membrane deposits, and here it is variable. But most important feature of type 2 is something called as dense deposits within the base membrane. This base membrane deposits, which I've told you here, are going to be the most important. So they form something called a dense deposits within the base membrane. And that's why this type 2 is referred to as something called a triple D, dense deposit disease. And please understand the fact, if in exam, if you want to differentiate between type 2 and type 3, there are only two things that can differentiate type 2 and type 3. One is the mesangial rings, and second is the electron dense deposits within the base membrane. These are called dense deposits within the base membrane, that is triple D. So here you will not have dense deposits. So it's not a triple D. So that is why this type 3 is also referred to as sometimes C3 glomerulonephritis, where you don't have any other findings of type 2, but you will have only C3 deposition. And the deposits are variable. You can see anywhere within the glomerulus, doesn't matter, but very commonly it will be subepithelial and subendothelial region only. But you can see elsewhere also, not a problem. But only C3 deposition, no dense deposits, that's C3 glomerulonephritis or type 3 glomerulonephritis, a type 3 MPGN. So that's how it is. So which means the only thing that differentiates type 2 and type 3 is the presence or absence of dense deposits or the presence or absence of mesangial rings. And type 1 is actually quite simple. You will have C3 deposits and immunoglobulin deposits. So in immunofluorescence itself, you will be able to pick up much easily. Not a problem. And then we have the complement levels. Complement levels typically in HCV and cryo, there will be low C3 and C4, both will be reduced because here the alternate complement, because most of them are due to infections, which means microbial components will be activated. So most of the times along with that, circulating immune complex will be there. So there will be low C3 and C4, and cryo is something is a CTD. So circulating immune complex will be there. So low C3 and C4 will be there. But whereas in type 2 and type 3 MPGN, you will have only low C3 because it's purely C3 consumption. There's nothing else. You might have only low C3, nothing else. And as far as treatment is concerned, treatment is usually treatment of underlying cause, because most of them it's secondary. Most commonly it will be secondary only. So treatment of underlying cause. So that itself is enough for type 1. Whereas type 2 and type 3 depends on what you're dealing with. So you'll be usually starting with immunosuppression. So if it's primary, I can start with, because most of them will be primary. We don't know the underlying cause. So we have to start with some immunosuppression protocol. That's what we need to do. Sometimes eculizumab might be helpful. Eculizumab might be helpful because it's an anti-C5 monoclonal antibody. We know that. So, but nevertheless, like you need to know what is the underlying cause. Once you ruled out underlying cause, then it becomes quite simple. Then there are few other glomerulonephritis that can have organized deposits. I think I can tell later on, because there are some few other glomerular disorders that can produce organized deposits, and at the same time they can also result in nephritic or nephrotic syndrome. So, but there are few things which typically comes with nephritic syndrome. Like for example, you have immunotactoid glomerulonephritis, and we have something called a fibrillary glomerulonephritis, which can come with nephritic kind of presentation as well. So this is the entire view of what you typically see in the membranoproliferative glomerulonephritis type 2. Type 2 and type 3, I told you, there's not much etiology, because Ankit is asking what is the type 2 and type 3. Type 2 and type 3, more often it will be idiopathic. More often it will be idiopathic in nature. Most means it's mostly primary. But if you want to know some secondary causes, it can be malignancies, or especially CLL, or some infections can produce type 2 and type 3 also. But more often type 2 and type 3 will be idiopathic in nature. So now we are very sure that what happens in a MPGN. So now we know what is the light microscopic finding. Then based on other features, how can you differentiate between type 1, type 2 and type 3? And what are the complement levels? What is the electron microscopic findings? What is the light microscopic findings? What is the treatment that is given for these different types of MPGN? Okay, fine. So let us take a small break now, maybe for 15 minutes. So I'll be starting by 4:45 again. So where we can finish off the remaining glomerular disorders, and we can start with the renal failure. So I'll end the meeting now.